Good morning, everybody, on this fantastically warm morning in Aylesbury, which is my local patch. So I'm really pleased that we're meeting in Aylesbury for the first time as a integrated care board. And I welcome all of the board members, but also welcome members of the public and other interested parties who have joined us. It's fantastic to see you here. Please make yourself comfortable. There's tea, coffee, refreshments over there. Help yourself. Don't hesitate. This is a meeting in public, which is not the same as a public meeting, which a public meeting can have a free-flowing dialogue, whereas this is a meeting in public. So it's being streamed, live streamed now, and everything is on and working, I'm told. Could I ask all members around the table, when you speak, there should be a button on that little box in front of you. Please do press that, and a green light will appear. That will mean your voice can be heard more loudly and recorded on the live stream as well. We've got some apologies, mainly due to ill health. Some board members are not here today. So Dr. Shaheen Jinnah, primary care representative, can't be here. Margaret Batty, one of the independent non-executives, and Sim Skavatsa, who's also unwell, also one of the independent non-executives. Saqib Ali, I should say, has to step out at about 11, I think, for about an hour. So early warning of that, and I don't think there are any other apologies that I haven't mentioned. Nope. Okay. Can we just have a look at the minutes of the last meeting, which is the last meeting in public, which was the 15th of November. And can I just ask you to raise any points of inaccuracy or changes? Page 1, page 2, page 3, page 4, page 5, page 6, and page 7. No? Very good. Thank you very much. Compliments to the scribes. Very accurate. Matters arising then. In the pack you will see a number of closed matters, so I won't refer to those. They've been done. And then you should see the summary of actions log. And can we just check through? Most of these are updated in terms of target dates, confirmation board level name, roles, freedom to speak. So Catherine, you have anything to add to that? No. As recorded there? Yeah. The next one, action 11, operation planning performance, that's today, covered today. Number 12 also covered today. Number 15, you have the update there on the approach to the 5-year forward plan. Action number 17 is that's completed. 18, Catherine?
The update on that. So I've talked with Sonia about the paper and agreed what I need to do is pick it up with Sim so that we do the work on how a proposed shadow board would connect to the board and then circulate that rather than a paper that's about the principles of setting up a shadow board. So yeah. I'll meet with Sim and do that, and then we'll get something round to the board.
Okay, thank you. And the next one, performance board quarter 2, that's covered today by Matthew. Number 20, the Kirkup report, initial response. Rachel, what's the latest on that?
So we took the deep dive for that through to Population Health and Patient Experience Committee. I was trying to just do a brief update on that, Chair, when we presented it.
Thank you.
Say that all again.
Please.
Apologies. Yes, we took a deep dive into Kirkup and the recommendations for that through to the Population Health and Patient Experience Committee earlier this month, and I plan to do a bit more of an update on that with the Chair's report that comes through on the committee.
Thank you very much. Number 20, that's covered today by Rob Bowen later on, and that is the full list of actions. Okay, so with your permission, move straight on from that, please. Declarations of interest. The current register was attached to the papers. Some of the items on the agenda today do affect some of the representatives in the room by the very nature of what we're going to be talking about. But none of those papers require any decision, so there's no conflict that needs to be declared above and beyond what's already recorded in the papers. Is that right, Catherine?
Okay. So one of the reason we will publish the register as of the date for each board meeting, it's as a prompt to individuals to let us know if there's anything missing. So Rachel's got something to add, and Neil and I have talked about making sure his interests are registered.
Rachel, do you want to come in?
Yes, just to note that there's a change to my husband's role on the members' interests.
Yep, you'll record that. And who was the other one? Neil, did you say?
Neil's going to let me have his because we haven't got him on.
As a new member, yeah. And Tim?
I have a slight change to one of mine as well, which I'll let Catherine know about. It doesn't affect anything we're talking about today.
Nick?
Yeah, I've got a slight change as well, Catherine, so I'll let you know as well.
Anybody else? We're on a roll now.
So clearly a good plan.
Really important to keep that up to date, please. So please don't wait for board meetings. Just let Catherine know any changes. Thank you. Questions from the public. So this, as I say, is a meeting in public, not a public meeting. So we're happy to take questions related to the agenda items from members in the public. Where those questions arise, the presenters of those particular items can answer those questions where they are relevant. Irrespective of that, we have an agreement to publish answers to any questions that are received either in the meeting or before, within 20 days of the board meeting, and that's what we've been doing custom and practice since last July. There was one question received in advance of this meeting. And Catherine, we're not covering that in the agenda today. So we will produce a written reply to every aspect of that question within 20 days.
Yes.
Yeah. I know the questioner is in the room, and so you understand the logic of that, and you will get the answer that you, or the questions that you've asked. Is that an agreeing nod or not? I think, I mean, it's okay for you to speak. If there's
Well, I'm disappointed that you're not broadcasting to everybody what your answer is, and having given you a few days' notice of the question seems a disappointment to me.
It's only following the kind of approach that, because there isn't an agenda item today, otherwise we'd get into a detailed discussion now, but we will broadcast the answer, it just won't be live, like this, it will be on our website. And then you have every right to come back on any aspect of that you felt hasn't been addressed appropriately. It's because it's not a public meeting. That's the difference here. Okay. And there weren't any other questions received in public. I can't see any other hands raised. Okay, thank you very much. On to the next item then. So, living our values. So, we've got this series of members around the board introducing themselves, something about themselves, and speaking about their values and how they connect with the role that they're now in on this board. And Aidan Rave has volunteered for today.
Thank you, Chair. Good morning, everybody. Just a few words on living our values, although I think I may frame it as a kind of aspiration and continual attempt to live our values, as I think it's much more of a journey than it is a destination, isn't it, having values. I think my values were really forged by three early experiences in my life where I was born, my parents, and those who I worked with early in my career. I was born in a former mining village. Well, it's actually a mining village when I was born there, but it's certainly very much a former mining village now in Doncaster, and it's called Aylesbury. And I look back now and feel very privileged that I grew up in that sort of environment, because I learned a lot from the people who I grew up with, those I went to school with, and those who I observed working hard and upholding the values of a close-knit community, despite many challenges that were thrown their way and that are very well documented. And even to this day, some of those villages up and around the north of England certainly still struggle from some of the challenges that were thrown at that time, but still have that inbred community spirit and that kind of resilience to overcome. So that was a big foundation for me. As were my parents, who came over to this country in the 50s, over from Ireland. So created and established themselves within that community, and brought a lot of the values that they had grown up with, but also integrated themselves with that close-knit community that I was talking about. And I think the third element of that formation of values was really from some of the early jobs that I had, and some of the people who I had the privilege to look up to in those jobs. At the time, I'm not sure I knew what they did for a living, because they worked in something called the voluntary and community sector, which was an entirely new concept to me, coming fresh out of university. I think in the post-Barack Obama era, we'd probably now call it a community organiser, because that's what he did, and now everybody seems to know what that job was. But then it wasn't so clear-cut. But these were people who could see some of the challenges that were surrounding them in their communities, and quite simply stepped up and decided to do something about it. And I had the privilege of working with a couple of these people, and now look back with absolute awe at what they did. Kind of wish at the time I'd spent more time talking to them and understanding what they did and why they did it and what their motivations were. But it certainly had a long-lasting effect on me, and has had a real kind of impact on my values going forward. I think that's created for me a sense of what my values are. I think they relate to authenticity, about being yourself and bearing testament to who you are, about being courageous, taking decisions that need to be taken, and having the wherewithal to stand behind those decisions and be accountable for them, rather than ducking under the table when things get difficult. Again, something that really was given to me when I was younger. They're also about resilience, about the fact that you won't take a smooth, simple and straightforward path to your destination. You're going to get knocked down occasionally, and you've got to get back up again. But fundamentally, be ambitious. Be ambitious for what you do, and be ambitious for the people that you work with. I've chosen a path of working mostly within the public sector and in public service, and I think it's really important that as public servants that we're ambitious for what we do, and we're ambitious for the services that we create. I'd like to just leave with a little quote that is something that I think I've always found frames those values really well in context, and in the context of the urgency of the time that we're here. And it's a quote from a guy called Bill Bryson, who's a very good writer, and I'm sure many of you have read a number of his books. But it relates to the period of time that we're here in the great expanse of history. And so he says, "Consider the fact that for 3.8 billion years, a period of time older than the Earth's mountains and rivers and oceans, every one of your forebears on both sides has been attractive enough to find a mate, healthy enough to reproduce, and sufficiently blessed by fate and circumstance to live long enough to do so. Not one of your pertinent ancestors was squashed, devoured, drowned, starved, stranded, stuck fast, untimely wounded, or otherwise deflected from its life's quest of delivering a tiny charge of genetic material to the right partner at the right moment in order to perpetuate the only sequence of hereditary combinations that could result eventually, astoundingly, and all too briefly in you." Now, the reason I use that quote is because we exist in human form, at least, for the blink of an eye. And in that blink, we've got an opportunity to do something, and to do something, particularly when we're public servants, something that's positive for our fellow community. And so I think the urgency of what we do and the privilege that we've got as public servants really should bring those values of authenticity, courageousness, resilience and ambition to the fore, because we get a few years to do it, and we get a few years to leave the world in a slightly better place than the way that we inherited it, for those who are going to follow in our footsteps and comes next. Thank you, Chair.
Very helpful, thank you. Then Chief Executive Director's report. Steve.
Thank you, Chair. So for colleagues who have joined us from the public, I'm Steve McManus, Interim Chief Exec of the Bob Integrated Care Board. I'm going to take broadly as read the paper, but I'm going to draw out some highlights probably from the front end and then give enough time for any kind of questions, and certainly don't want to cut across some of the sort of subsequent reports that we've got where we've got kind of more data on kind of quality and performance and finance and some of the other topic specific areas. I want to start just by really recognising the pressures across our health and care and voluntary sectors that we've all experienced and seen over recent weeks and continue to do so. And I know Matthew will touch on some of that, particularly when we get into the performance report, but that may well be a thread through a number of our conversations today. And I think, you know, I would like to put on record a huge thanks and recognition to our colleagues in the kind of healthcare and voluntary sector who, under really difficult circumstances, have been doing their absolute best to provide kind of services to our population. And I say, we will come kind of into that. So a bit of an overview of some of the sort of system areas from the last couple of months. So in that context, we have seen strike action from the Royal College of Nursing that affected 3 of our hospital providers across Oxford Health, Oxford University Hospitals and Royal Berkshire Foundation Trust on the 15th and the 20th of December. Further kind of action is expected, albeit the action that's being taken, I think, Rachel, on the 18th and the 19th of January does not affect this time round our geography, but we were the geography in the southeast that were affected on the 15th and the 20th of December. And further to that, there was also GMB action that affected our ambulance service in South Central Ambulance Services on the 21st of December, and again more recently on the 11th of January. Really again want to pay testament to the significant preparation that our own colleagues within the ICB, working with our provider colleagues and also working with the unions locally to mitigate some of that impact. But a sign of the times in terms of some of the challenges within our kind of health and care sector around the sort of disquiet from members of staff, whilst also trying to maintain services at the same time. We, as part of our requirements, had an assurance session with the South East region on the 6th of December. That was our Q2 ICB oversight meeting with the regional team. It's a wide-ranging review from some of the programme activities through to some of the structural development of the ICB, to some of the particular areas around health inequalities and the work we're doing also in terms of local partnerships. The region took positive assurance, and we've had that kind of formally back in writing from the regional director regarding the progress of the ICB and the wider BOB system, kind of recognising though that there is absolutely kind of more to do around a whole range of different areas, kind of including some of the things we're going to hear about today in terms of our ICP strategy, how that translates into a longer term delivery plan, and how we continue to improve, adapt and develop the way that we engage with our kind of public and are transparent about the things that we're actually doing as an ICB and bringing that more and more to the attention of local residents and local populations. Just want to move on to some of our specific partnership work, and you'll notice in the Chief Exec report this time round we're trying to draw out some specific focus around our local government partnerships and other partnerships within the voluntary sector, and also the way that a number of our provider partners are forming around provider collaboratives, and also importantly what is happening within our 3 place systems as well. So we continue to develop our essential relationships with, say, some of those key partners. Stephen may want to come in around some of the particular local government areas of focus, and it's really important to recognise the wider consideration that some of our partners have, not least council elections coming up, but also the fact that at the moment all of our local authority partners are completely engaged in their budget rounds that sets their financial considerations for the coming year, and that's an area that will be I think all-consuming, Stephen, as you go through this month and into February as well. Do want to draw out some of the partnership work with local authorities, particularly around the national discharge funding that has been made available. So £500 million was announced by government prior to Christmas, with a 12 million allocation across both health and local government for this system to generate further capacity in the health and care system to support patients being discharged from hospital into domiciliary care and other forms of local government placements and other care placements. There's been a further 200 million announced nationally, and again, we're just working through the local share around that for this system to again further provide capacity at this very acute period that our health and care system are seeing in terms of pressures in particularly the acute and community health systems, but how that translates also into our care sector as well. One of the important considerations for us is that actually we take a longer term strategic view around this with our local authority and voluntary sector partners. So we know that some of the government announcements about funding into 23-24 and 24-25 increase that discharge funding and that funding for local authority and domiciliary care kind of placements. And one of kind of our roles within that is to work in a more kind of strategic way over the next period, so as we've got more sustainable capacity across the health and care system to support our residents going forward. I do want to just touch on a really excellent session that we had with the voluntary community and social enterprise sector, who came to one of our development boards recently to talk about the role of the voluntary sector and how we can increasingly become engaged in working with the voluntary sector, who provide significant support around health and care services to local residents, to vulnerable groups, and also often into some of the most socioeconomic challenged environments and communities as well. So you'll see more of that relationship coming through in our discussions within the board going forward as well. In terms of partnerships, really important to note that within our provider environment, our acute provider collaborative between Oxford University Hospitals, Buckinghamshire Healthcare, NHS Trust and Royal Berkshire Foundation Trust continues to develop. There is a MOU now in place, a Memorandum of Understanding between the three organisations in terms of how they work together around a particular programme of work going into 23-24 and beyond, around areas such as the recovery of elective services and reducing elective waiting times, alignment about their digital capability, and further efficiencies at scale in terms of some of their corporate services. Also, Nick Broughton, Chief Exec of Oxford Health, who's here on the board, with his counterpart Julian Ems, have again further advanced the mental health collaborative between Berkshire Healthcare Foundation Trust and Oxford Health, again with a range of delivery commitments over this next period in terms of how the two mental health organisations in our system will work together at scale on some of the things that they are able to do through that relationship. And then finally, really important investment in our local systems, our places of Buckinghamshire, Oxfordshire, Berkshire West, and recognising also the relationship in Berkshire West of the three local authorities in that environment, in terms of strengthening relationships between local government, our health providers, voluntary sector and community groups at place level, so as actually we can continue to develop services that are local and relevant to citizens in those three places. I'll just pick out a couple of other highlights, Chair, and then stop, because many of the other things in here are covered in more fuller reports. I do want to just note, under people and organisational development, that internally within the Integrated Care Board, within our organisation, we have started formally a consultation with our people that moves from that development of 3 CCGs into what is the Integrated Care Board as an organisation, and now the next stages of that is to develop the more formal structures that either bring teams together in terms of our capability to do things once at scale across the geography of our system, or make sure that we've got the right capacity within our 3 places to support the work of the ICB at that level. So important next steps in terms of the next 4 weeks as we go through that consultation with our own staff. And I just wanted to highlight as well that we've also started the work to progress the substantive appointment of the ICB Chief Executive, adverts this month with a timetable that would lead to interviews being held in the early to middle part of March, and similarly with the substantive appointments of the remaining executive roles, we have got a programme to undertake that recruitment which would culminate in appointments towards the latter part of March, early part of April. On the agenda, we've got some important areas that update board colleagues and the public about the work we're doing around the integrated care strategy, and Rob Bowen will draw that out and its connection with the 5-year forward plan, and also how that then works into the planning guidance and our response to that for 23-24 as well. I'm going to stop there, Chair, because I think many other areas of some of the operational performance, finance, we can either pick up through questions or within my colleagues' reports as we go through the meeting today.
Thank you. Do any of the other executive want to add anything? That's all covered. Thank you. Very good summary there. Questions for Steve and the team? Sakib.
Yeah, thanks, Steve. I just wanted to ask on number 27 about the urgent care centre that's opened in Reading. So I think that opened on the 5th of December. So how the demand is going, how the so I wanted to ask about the urgent care centre in Reading. So I understand it opened on 5th December with 100 sessions a day, 50 that can be booked and 50 that aren't. How that is helping alleviate demand, and also if somebody could clarify what the difference is between urgent treatment centre and care centre. So I think it's to do with illness rather than like more complicated things.
Matthew, do you want to pick that up?
Yes, happy to, and happy for colleagues to add a bit of sense. So yes, we've seen that established on the 5th of December. We've seen reasonable demand going through that. We haven't quite reached the 100 per day level yet. We're still working through some of the referral patterns. So how do we get more electronic referrals from the ED department, automatic referrals rather than telephones? We're working through some of the logistics of that. I think it's a bit too early to tell on the impact. I think we've got to give it probably a reasonable time frame to review the impact and the relationship with the more minor presentations at the Royal Berkshire Emergency Department. So I wouldn't want to jump to any conclusions around that. Urgent care centres generally have they tend to be focused in terms of GP workforce, whereas the UTC has a slightly wider range of services and more of a medical support model. So that's the distinction. There is a national definition for urgent treatment centres. These urgent care centres don't quite go to that range of services actually, but they have been seen as a really effective way of intervening and trying to alleviate some of the demand in the system. So whilst your question was about Reading scheme, we've seen a lot of focus in the Oxfordshire patch around establishing additional urgent care centres, one at the Horton, and we're looking to establish one at the Oxford JR site as well. So generally felt to be a good positive intervention. Need to allow ourselves the time to do a full evaluation.
Thank you. I mean, I was expecting you again to say that they were bursting at the seams, simply because obviously from what we hear about GP inability to obtain appointments, etc. So obviously because it's new, I understand it will take time.
Rachel, do you want to just pick up the interface with primary care as a sort of extension of Sakib's?
Yeah, absolutely. And we are whilst there is obviously variation across the system with respect to access to primary care services, and we are really focused in focusing on those areas that perform less well. actually, as a system, we have extremely good access to same-day and next-day GP appointments, and also within 2 weeks we're above national average for that. So whilst there is flow of patients to urgent care, urgent treatment centres, our primary care teams are also providing more appointments than they've ever provided before, and we will continue to try to improve access and experience for patients.
Okay, thank you. Tim. And then Nick.
Thanks, Jared. Thanks, Steve, for the report. Paragraph 12, which is about the allocation of the National Discharge Fund money, 12.2 million. I was just curious about the split between what I would term, perhaps incorrectly, NHS funding, the 7.7, and the balance to local authorities, 4.5. Are we, as a system, comfortable with that split? And does it, I don't mean this flippantly, but does it matter? Because if we're working hand in glove, I assume we can manoeuvre the money around. But what's the significance of the split? Because from the outside somewhat, one hears that the bottleneck is in the social care to help the discharge route, and I would have intuitively thought more money would go to the local authorities and slightly less to the national NHS, but clearly that's not the case. I was wondering why.
So if I give the sort of headline in the rationale, and then I might see if Stephen wants to develop that. So the headline rationale allocation was that the split was a proportion that would be through weighted population going to the ICBs and to help into the Better Care Fund to effectively purchase additional capacity, whether it's care placements, domiciliary capacity, and directly to local government to recognise support that may well be needed for local authority workforce, and to either support an uplift in that workforce, to recognise some of the pay differential challenges that local government are facing in the care sector when trying to employ and retain care workers through local government, whether it's directly or through their private sector contracts and capacity. So that was the rationale for the split, to provide some direct support to local government for that
so in
workforce.
my layman's terms, so to speak, even the 7.7 that's quote NHS, the reality is the majority of that will be spent on social care placement in the community. But we're commissioning it via the NHS.
So to go through the Better Care Fund to be decided upon jointly between health and care in terms of the best use of that funding to get the most capacity we can that supports patient citizens discharged from hospital.
Fine, thanks, Steve.
Stephen, was there?
I'm a little anxious you could be the next DAS. You've given such a really comprehensive answer, Steve. It's a really good question, Tim, and I think the important thing is, as paragraph 12 says, any plans for the use of the money, either the NHS element or the local government element, has to be agreed jointly, developed through the Better Care Fund as the methodology. And for us as the board, we've got to really remain true to that approach, because it's only through using that partnership approach, that joint approach, will we make sure that we're making best use of this money. Because whilst any funding is greatly received, whether it comes through the NHS or local government, we have to be careful that it doesn't bring with it some unintended consequences. So this funding is great because it goes into next year and it's recurrent, so it allows us to make long-term plans, which are really, really important for sustainability, never mind value for money. You will have picked up an additional 200 million announced by the Secretary of State to support hospital discharge, primarily through buying care home beds, which is less helpful because it focuses solely on beds, and we've got to remember it's important that we help people get back home quickly, effectively and promptly, and moving from one inappropriate bed, i.e. waiting for discharge in a hospital, to another inappropriate bed, i.e. a poorly funded, poorly commissioned care home placement, is not going to be good for that patient and their recovery. And of course, it's time limited. That funding, so therefore there's a real risk that there's a subsequent pressure on local authority funding, or indeed on the individual's personal funding if they're going to be
funding. So for us, and this is why this discussion is really good, it's really important for us that we're not doing anything that has an unintended consequence on one partner or the other. Hence why I was really pleased to see the starting point being discharge arrangements have to be agreed through the Better Care Fund at a place level.
Yeah. Thank you. Nick.
Thank you. I just wanted to say something with reference to the mental health provider collaboratives, which Steve has referenced in paragraph 15. So for some time now, we've had 3 provider collaboratives covering specialist mental health services, specifically secure services, CAMS Tier 4 services and eating disorder services. And these are led by Oxford Health, and we have delegated commissioning responsibility for those services. And they extend beyond Berkshire Health, so they include a number of other NHS organisations and indeed independent sector organisations. But in addition to that, the 2 mental health provider trusts in Bob are working increasingly closely and looking at other areas where we can develop a provider collaborative approach, for example, female psychiatric intensive care unit provision, and we are looking to replicate the approach we've adopted with Oxford University Hospitals, so to have a provider collaborative underpinned by a memorandum of understanding, and that work's being led by the 2 trust directors of strategy.
Super. Thank you very much. Can I just ask a question, Steve? On paragraph 16, where you refer to the a place-based partnership development, and we're going to get a report in March. Will that report set out the detail in terms of a timetable for devolving budgets and responsibility for services to place-based partnerships? Is that the time where we agree that, or is that later down the line?
Yes.
Yes, that is the time, right?
Yes, and it will be evolving, because I think 23-24 will be a transition year, because where we are able to look at some of that delegation will, when we're talking about delegation around use of resources in terms of service provision, will likely to be more around some of the hypothecated funding that we're seeing coming through that's above and beyond necessarily core budgets. We have to then support the development of the place-based partnerships in terms of how at a local level, within kind of service lines like urgent emergency care, they are also able to develop the use of the wider core budgets in terms of how to change service provision, and that may well mean an increase in investment in certain parts of the local place and less in others. But that's something about the maturity and the work of those place-based partnerships together to agree that across those partnerships of health, local government, often the voluntary sector, and community representatives.
Very good. We look forward to that. I mean, it's a critical milestone in our journey to integrated care, health and care, and everybody, I know all the partners are waiting for those for that kind of clarity.
And last point on this, right, it connects with the point I made about the real importance at the moment of the internal ICB consultation we're going through, because part of that in terms of our structures is to get the right capacity for the ICB at place to be a really strong and good partner within the place-based partnerships, and to use some of our convening and support and development capability at that level to actually support the work of the place-based partnerships over this next 12 months.
Thank you. And before we move on, can I just on behalf of the whole board also record our thanks to all of the work that's been going on from the people in the ICB, the wider partners in local authorities, the voluntary sector, our frontline hospital providers, GPs, all of the other health workers out there in very, very difficult times. I mean, by every account, this is the most difficult winter in people's living memory, and it's not over yet. These are really, really tough times, great deal of political interrogation on everything that's moving as well, and huge and enormous public expectations. And people are doing their level best in those very difficult circumstances. So please record our thanks in the minutes, I think, for everybody. And you know, and I know certainly being closer to it behind the scenes of how hard people are working and the commitment that is there. People really are going the extra mile at these very difficult times. So thank you for all of that. Let's move straight on then onto the performance and quality dashboard. This is Matthew.
Thank you, Chair. And so this will be a bit of a theme, I guess, in terms of some of the discussion we've already kicked off. And I won't go through page by page in terms of the detail, but a little bit of context. So just a reminder to board members that this performance report includes validated data, so there is a significant time lag, and what we try and do in the narrative is get a little bit of flavour of the progress on performance, and then hopefully through these discussions I can bring perhaps a bit more of the recent information to light as well. Hopefully board members have also spotted actually a deliberate attempt to try and put more comparators in the report this time, so we're working on how we show that graphically, but actually in terms of the narrative you'll see a number of times references to our regional or national position, because in this environment of very challenged delivery and performance, I think that comparator is really important in terms of how some of the work we're doing locally reflects in our position. And actually, a lot of those comparators we do reasonably well. So I did want to touch a little bit on urgent and emergency care. I mean, we've touched on some of that in the debate already, and then just a little bit on planned care, and then I'm going to ask Rachel C to give a bit of a perspective around some of the demands. So in the urgent and emergency care pathways, we've heard already, it remains a very pressured environment and some challenge on terms of our standard delivery. In terms of the key metrics, you often see that in the delivery against the A&E 4-hour standard. We've included a little bit more detail in the pack this time around some of the work we're doing to alleviate and support that. So we've already touched on that in some of the recent announcements around discharge money, but we should also remember that we invested £8 million across the system in the demand capacity coming into winter that did bring on additional beds and additional services to support some of the demand. We also received an allocation of 1.1 million to invest in the development of acute respiratory hubs and the associated pressure around that in terms of primary care. So we've included a bit more on virtual wards in the pack, so hopefully the board members will see the focus on that, and also around discharges. So we've touched on discharges already. It's an interesting position on discharges. Comparatively, we do very well actually in terms of the number of our beds that are occupied by people who could be discharged from our acute setting, but actually at a local level it's still a real fundamental issue in terms of delivery. So I guess that shows the national challenge as well as some of our local challenges, but also perhaps highlights some of the good work that we are doing in that space. So hopefully that bit of additional information around virtual wards and discharges is helpful. In terms of the urgent and urgent care, we've again talked about it in Steve's summary. So the data in these reports is challenging. That has become even more challenging as we run up to Christmas. And I think we're going to hear from Rachel in terms of some of the challenges around flu numbers and also COVID numbers coming up to Christmas. So we saw some peaks just before Christmas in both those areas, and we went into a higher escalation level as a system. And our response to that was really focused around some of the areas I've highlighted around virtual ward utilisation, around an additional focus on discharges and some of the investment in primary and community capacity. Over the last week, I'm pleased to see we've seen the system de-escalate a little bit, but I wouldn't underestimate the pressure that our trusts and providers and partners are still under. So I'm going to stop there and perhaps ask Rachel to bring in a little bit of the urgent care element, and then perhaps I'll just progress to give the planned care highlights, and then Rachel's going to come back on mental health in a second as well. So Rachel.
Yeah, thank you, Matthew. And some of this was referenced in the Chief Exec's report. But just for board to note, I think there were three things that really drove up the pressures, and this was felt across the entire system. So first, the impact of infective group A strep. So some of you will have seen that written as IGAS. And I think what we saw there was in the region of about a 400% increase in demand for our primary care services, notwithstanding the phenomenal work that some of our clinicians did in reassuring clinicians across primary care and standardising protocols and access to medicines and self-management for that group of population. That then triggered increase in demand on our urgent and emergency care pathways in the acute setting, subsequently then falling into our inpatient bed base. And just to give you some comparison to what we saw this end of last year, I should say now, and the previous year, we had almost single-figure numbers across our system of inpatients requiring care for flu. That was a phenomenal, up to 70% increase in Christmas this year. And that was also felt in critical care as well. So you can imagine the consequences of that. And similarly, around COVID, we saw numbers of patients within our inpatient areas to those that we saw back in the summer of 2021. So again, both of those numbers having a big impact on our ability to move patients through our acute and indeed community and mental health and out into the system. And we established some infection control support wrapped around all of our partners so that we could provide consistency, risk assessments and support where needed for that. I think that's all I wanted to cover on infection prevention and control, Matthew, at this point.
And I guess just to touch on the primary care aspect around urgent and emergency care. So Matthew quite correctly alluded to increasing primary care capacity. So we put an extra 1,400 clinical appointments in between mid-December and early January. We've made sure that we're maximising the use of the urgent care centres that have already been referenced. And all of our places have acute respiratory hubs. So, for example, in Buckinghamshire, we doubled the 111 primary care hub case capacity and also put some more face-to-face respiratory support in. In Oxford, as an example, in their urgent care centre at Horton, we put some more paediatric support in. As you'll remember, before Christmas, there was a lot of attention around Strep A and paediatric presentations. So there's been a number of very specific initiatives that we've done across the system to try and relieve some of the pressure.
Thanks. So perhaps just moving briefly on then to planned care performance. So we remain on track for reducing some of our lower weights in terms of those waiting over 104 weeks is now virtually removed. I think there might be one or two complex cases at Oxford that still remain that are being treated this month, and good progress against reducing those waiting over 78 weeks with a target to remove all those waiting by the end of March. So good progress in that space. I think in terms of a live position, we have seen, so as you expect, some challenges on our elective activity over the winter, but also some planned reduction in elective activity as we hit that Christmas and New Year period. So we were very confident that we'll get there at the end of this year, but we have seen some of the numbers increase over the last few weeks, but that's to be expected a little bit over the Christmas period. Diagnostic numbers and overall activity numbers are still below where our initial plan was, but as I've articulated to the board before, that those initial plans were based on a different environment in terms of COVID prevalence and perhaps a different assumption around the level of winter pressures. So overall our activity levels are reasonable when compared to others across the system, but there are some particular pressure points, as we've outlined before, some particular issues around diagnostic capacity, both in terms of workforce shortages and physical capacity, and also a challenge around our cancer 62-day week numbers, where our performance is really challenged across the system. We've got some particular issues around staffing and pathology pathways around that, and good progress has been made in one or two of our trusts. It's clearly a real struggle to get momentum and absolutely back on track. We've seen some particular challenges at Royal Berkshire over the last few weeks that we're focusing on, and the BHT team have been working hard on recovery plans. So a real focus on cancer to try and get those numbers under control, but that does remain a challenged position. I was going to hand back to Rachel Sees. We are double act today to talk a little bit about some of the mental health challenges and performance. So Rachel, back to you.
Thank you, Matthew. And just to build on some of the information that Nick shared already around the successes of Provider Collaborative, I think whilst the report highlights us being under plan on much of our targets, we are seeing progress. And I think it's important to note the pressures are being felt across mental health services as much as they are anywhere else. We are seeing an increase in the numbers of out-of-area placements, and again, I think that's indicative of the pressures that we're seeing locally. We've got good plans in place with our colleagues across primary care to ensure that we are supporting those of our population that have got known learning disability and autism needs, so that they've got their regular and annual health checks in place to keep them well, and that work continues. We've just established our Mental Health Transformation Programme Board and operational oversight, so that we've got good traction around the monitoring of our targets and progress that we are committing to. So I look forward to coming back next time, Chair, and sharing some of the successes that we can see through that work. Thanks, Matthew.
So I think hopefully that gives a flavour, Chair and board members, of the performance in the system. Happy to open up for questions and comments.
Thank you very much. Question second.
Thank you, Matthew. On page 8, urgent and emergency care, over 12-hour waits. Obviously, there seems to be a massive difference between the three organisations, so I just wanted to understand how BHD was at 281. Is there an instance that has happened that caused that, or what is the story there?
Hold on, I just need to...
Over 12-hour waits.
I'm happy to comment.
Right, thank you. When I get to the right page, Rachel is happy to comment from a clinical perspective.
So all of our organisations have been pressured in different ways. Greater than 12 hours waiting is always a sign that there is an issue with flow, so there is insufficient bed capacity to flow patients into in a timely manner. And depending on, if you like, the capacity gap in our organisation, sometimes that is more prominently displayed in some rather than others. Hence, we have seen BHT under much more pressure than OUH and the Royal Berkshire. I think we should also remember that just prior to Christmas, it was BHT that needed to go into critical incident precisely for that reason, so that they could mitigate safety concerns around some of the flow issues. So that's why it's being evidenced in the performance report.
Okay.
Matthew, your cover sheet asks for guidance on suggestions to improve this report. So in that spirit, I've got a couple of suggestions really. One is that, so there are, and I know obviously ICB covers a huge range of stuff. There are over 160 information points in here, and I wonder, particularly for non-exec colleagues, as we develop this going into the next financial year, whether the board would want to think about what are the critical kind of 4 or 5 things that we really want to focus in on linked to the planning guidance, understand special clause variation, be quite rigorous in terms of exception reporting, and then recovery trajectories in terms of when we expect to get back to performance, because for reasons described earlier, it's a little bit of a sorry sea of red kind of in that regard. Again, I think my second point really for I think the Rachel's is that from the, obviously kind of access is quality. Again, I think the quality information in here, I don't particularly understand the value of reporting number of serious incidents, for example, when there are other things to look at in the quality space which we may want to develop. And then my last comment really is that there isn't any mention in here or anywhere else, I don't think, of the workforce, and given they're such an integral part of kind of everything that we do, whether or not specific kind of overall views of the workforce might be something that the board want to consider.
Very, very helpful suggestions. I think I'll just take a comment from Aidan as well, and then maybe come back on those thoughts.
Thanks, Chair. Probably more of a thought than a question per se, but the issue of discharge and thinking ahead, I mean, clearly at a macro level, there is a huge challenge around the structuring and the resourcing of adult social care, which, you know, is well documented. But at a more local level, are there realistic opportunities for us to move the dial in terms of some of those numbers that we can see there? I'm looking at slide 12 particularly. I think it's which says, I mean, puts us in reasonable in a reasonable position in relation to the wider southeast region. I think we're at 13.4%, the region's at 16.4%, but clearly, you know, marginal gains within that number could have a huge effect in terms of the kind of wider impact on the system. I guess it's you know, over the kind of quote unquote downtime of the summer, are there opportunities for us to be able to focus on moving that dial in readiness for the challenge that we'll no doubt face when we get to next winter again?
Thank you.
So perhaps I'll do that one first if I can, and then perhaps come back to the helpful suggestions from Neil. So I think my response is, from what I see at system level, is absolutely there's areas for improvement. If we look, for example, at some of the the complexities of the pathway, of the assessment route, some of the work that we're doing, I know Neil directly involved in some of the Bucks improvement work, but I just feel there are lots of opportunities in terms of integration of different types of services along the pathway and the assessment process, getting transfer of hubs embedded across our system, sharing some of the real best practice that we do have in different systems. I think there are good opportunities for improvement. We do need a bit of space, I think, to do some of that broader service redesign and invest in some of the support, the analytics support and the digital support around some of the options. But I do think there are opportunities for improvement, if that's the broader question. And I think if we looked operationally, while we compare well, I think our services are not as effective, and we can improve and do better for our citizens. So I think there's lots of opportunity there. There will be some financial constraints around that, and that's what we'll have to balance as we go into the new year. Neil, really helpful, Neil, to get that. We continue to evolve this. I think we have constructed an executive summary, but I think it's probably a fair challenge to say those metrics are probably not the right ones to have in an executive summary, and we need to refresh them as we go into the operating planning process for next year. And I think, for example, recreating a A&E trajectory as we go through that planning process, I think will be really helpful, because to keep comparing ourselves to 95% level just feels like a false presentation. So I think some really good points there. Neil, happy to take away the workforce one. I think we probably need to work out how often we bring workforce reports here. Do we embed that in the regular monthly performance reports, or do we look at a more detailed quarterly report on workforce trends? But always appreciate feedback on the development of this. I think there's a lot of development to be done. We need to balance the level of detail coming to the board with the right level of messaging. So happy to take that away.
Very good. Rachel Corser.
And just to reassure board that the Population Health and Patient Experience Committee in November received our quarterly quality report, which details many more quality metrics. So there's a summary of that within the Chair's exception report. But I think, as Matthew said, and actually we were just having a conversation pre-board about having another review of the measures and the metrics that come through in the quarterly report for next month. So perhaps we can bring Neil into some of those conversations to support.
So I think that, just to summarise that bit, the challenge is, in terms of what you bring to the board, is not more but less. Less and much more focused about the things that matter most, and those also being aligned to the operational plan, which is yet to be agreed, the 5-year forward plan, and the connection with the integrated care strategy. So this sort of the golden thread all the way through. How does it all connect about what are the things that are most important to the people of Bob, and therefore this board needs to focus on. That's not to say the other stuff doesn't get done. Of course it does, and you have to do your reporting, and NHS England expect all those reports to go in, and the various committees can look at that in far more detail. I think the challenge is, how do we think about what do we bring here to generate the most important kind of discussions, conversations, and direction? Not easy to do, I know, because you've got so many pressures on you and so many demands, but less may be more. Can we leave that challenge with you?
Yes, leave it with
Great. Gratefully received. Thank you. Thanks very much. Let's move on then, on to the finance report. Jim.
Thank you, Javed. I will just, I'll take the report as being read, and we'll only pick out some highlights, and then thank you. Then happy to take any questions on it, really. So you will see from the report that there has been a significant improvement in both the month 8 in-year position and the forecast outturn, which has gone down from 90 million to just under 50 million. And I have to say that is thanks to all colleagues within Trust and all of the Trust support in order to deliver that position. So that is an improvement. The request now is that we have a stretch target of 44 million which is a requirement of another improvement, which we will be working on and reporting on next month. So there are still, having said that, significant challenges within the system. Overall, you can see that across the patch, the pay spend is considerably higher than anticipated at the beginning of the year. That has a double impact on us. It impacts on our ability to deliver efficiencies, because the efficiencies primarily were in pay areas. So again, we're in a bit of a double whammy on that. But we continue to work together as a system to deliver the stretch target that we will be given. I think the other bit that I would just pick out is that in terms of the capital spend, we are currently showing a small predicted overspend, and that has been raised at the Productivity Committee, partly because of the big underspend to date. In terms of the overall spend is quite low compared to plan, but we are predicting a small overspend, so we will be working with all the providers to bring that back in line with the challenges. And one of the things that the Productivity Committee has asked for is for the top 5 schemes within each of the providers to get a breakdown of what the spend is between now and the end of the year, so that we've got a bit of assurance round about what the capital programme will be actually going to deliver.
Thank you. Any questions for Jim? Nick?
Jim, sorry, you probably gathered by my facial expressions, I was trying to process things there. So just so I'm clear, are we saying, although we're underspent in relation to capital currently, we project that we will overspend?
Yes.
Unless we do something?
Yes.
Fine. Okay. Thank you.
And we're significantly underspent to date.
Okay.
Tim?
Thanks, Trevor. Thanks, Jim, as well. Just for the benefit of the board, we'll talk about, we're going to feedback a little later anyway, but the one area, as well as capital, which Jim and Nick have already spoken about, the other area where we want to deep dive a little more is in the CHC position. So the areas that are tracking overspending, we've
community healthcare.
Continuing healthcare.
Continuing healthcare.
So we looked into prescribing, and we got a very good report at that last meeting, which gave us some good reassurance. And similarly, we will be doing the same on continuing healthcare. And obviously, pay is the other area where we know all the workforce pressures that there's some challenges, to say the least, and we're keeping a close eye on that. But it's hats off to the team. I think they've done a great job across all the providers in trying to get us back on track as much as we can.
Steve, and then Stephen.
Yeah, Jim, I just wonder if you could just expand a little bit in terms of what we're doing across this quarter to tee ourselves up as a system in terms of financial efficiencies going into next year. Just think it's important that we log that, because we've got some really important work to do this quarter to put that kind of programme and capacity, so as we've got some system-wide opportunities that start to land for us from April kind of onwards. So, and that's been a bit of a theme that we've touched on through this board over the last 3 or 4 months.
Yep, happy to do that, Steve. So people will remember there were 8 system-wide schemes that we were going to help deliver against the £22 million CIP target for a system as a whole. Part of the reason that those have not advanced as much as they possibly can was that we haven't put the structure round about that and the resources round about that in order to make it happen. So what we have done is we've identified those 5 that are actually 4 or 5 that are definitely cash releasing, whereas some are about productivity, like theatre systems, and there are other mechanisms in place like the elective care board, which is probably the right place for those to be managed. But those 5 we will start to put the resources round about, and we'll put a project management structure in there. We've already had some conversations round about that, and O'Neill leads the pharmacy one and has expressed wants additional support round about that. So we're putting together a proposal that will go back to the leads of the schemes in order to see whether or not people are comfortable with that, and start filling that in order to get the programmes up and running early now, so that they're in a better place to deliver. In terms of the one that I chair, which is the commercial work stream, we are going to have an away day or a half away day with the commercial, with the procurement, because there's a bit of an overlap with procurement, to identify those key areas that we will be developing for next financial year, so that we're working on those now, but we'll have a clear idea of what the areas will be that will deliver the savings next year.
So really good. I just think through the System Productivity Committee over the next couple of months, I think seeing those unfold are going to be really important, and then maybe in the finance report in the public board in March, kind of setting out actually the sort of meat of that programme into the next financial year would be, I think, really helpful. That gives us the next couple of months to unfold that, get the right kind of programme, structure, capacity kind of in place, but to also get the sort of oversight and assurance from the System Productivity Committee about how that's progressing.
Yeah, that would be very, very helpful. Stephen Chandler, then Rachel.
Yeah, thank you. It was just to follow Tim's point about CHC being a pressure, which it has been throughout the year. We have to be really careful, because obviously CHC and the award of CHC is set against a national criteria. So the challenge for us is ensuring that that criteria is being applied consistently and appropriately, not see CHC expenditure as something that we shouldn't be incurring. Because it's that decision that has the financial implication. And if it's not an implication for the NHS, it will be an implication either for the individual themselves, if they're a self-funder, or often the local authority. So it's really important we manage any change to CHC, firstly in line with applying the criteria consistently and robustly, and then supporting the impact of that, whether it's on the individual or on the local authority. Otherwise, it risks undermining some of the positive work we've been doing around partnership, and indeed creating a real sense of tension between us and our patients.
Thank you. Rachel Cole. Sorry, take Rachel and then back to you, Jim.
Sorry, yes, and just because it was noted in Jim's report that there's a prescribing pressure, I just want to reassure the board it's not because primary care is prescribing any differently, it's because prices have inflated. So, for example, there is no cheaper stock option. If there's a supply chain issue, we can't get cheap generic stock. An example might be something like alendronate, which is prescribed to older people to prevent fractures. The lack of available cheap generic stock means that we're paying 10 times the price this year compared to last year. So that aspect of the prescribing pressure isn't something that we have direct control over.
Would you agree, though, that there is an opportunity around medicines optimisation?
I agree there's an opportunity around medicines optimisation, but not in terms of reducing that particular aspect of the cost pressure. There absolutely is an opportunity in terms of efficiencies.
Anyway,
yeah,
okay. Jim.
So just to pick up on that last point, first of all, what we have started to do is, in part of the prescribing report that went to the Productivity Committee, was giving the assurance that those areas where we'd identified cost improvements within the prescribing budget would be delivered, and there is plans in place to deliver that. So there is still ongoing work in terms of delivering some savings within the prescribing budget. The overall prescribing and pharmaceutical element is looking at the whole spend across the acute providers, community providers, mental health providers, GPs, and where there are opportunities across that batch. The second bit is absolutely in terms of the CHC. One of the things that the Productivity has come in is it is a really complicated area. It's an area that we do need to bring people up to speed in terms of what is the understanding round about it. So that's the purpose of the Productivity Committee's view of that. There is also work that Rachel is leading in terms of the transformation of that, which quite rightly involves the local authority as well.
Thank you. Tim.
Yeah, thanks, Stephen and Rachel, for the feedback on those two areas. One thing specifically, which I should have said when I last spoke, is that despite the focus on bringing the deficit down, one thing that the System Productivity Committee constantly looking at is that this shouldn't be done at the expense of our residents and patients. We're very clear that it's not all about the money. The money is very important, but it's not solely about money. It's about productivity, efficiency, and delivering well for the residents and patients. So Stephen's point in particular about CHC, while the number is above the target, it's not that that means we should be slashing or anything like that. Absolutely not. We want to understand more thoroughly why that is, and understanding again that it's a system conversation, not any one part of the system. It's not about moving the challenge from one side to another. We've got to work collectively to do it the best we can. But very constantly we're referring back to what does this mean for our residents and patients? Is it the right thing to do? And as Rachel said, there's some things where we can't magically get the cheaper drug. We have to just do the best we can. And prescribing is a great example where the report was showing the levers that we can pull, the team are pulling very effectively, and it was a very reassuring report to see.
Thank you. So in summary, let us just record our thanks to Jim and the whole of the team here and all of the chief finance officers across the providers. In particular, in previous reports, people remember we were looking at a budget deficit, in-year budget deficit of well over £90 million. That has already now been brought down to 48, and a strong indication there that it will be brought down to 44 million, which is what we've been asked to do by regional NHS. That is a phenomenal achievement with all of the pressures that we've talked about already, the demand-driven pressures that we're facing. So many thanks to everybody who's putting in effort behind the scenes. It's not over yet. There's a lot of work to do. I mean, that is in the context, of course, of Bob as a system being having the lowest per capita funding in the country. So our starting point is very, very low. If we were brought up to where we think we should be, we'd be talking about well over £70 million of additional core funding would come in to Bob. So, and members of the public may not know this about how severe that historical inheritance that we've picked up. And we're making representations as well as we possibly can at a national level to try and get colleagues to address that. There's no magic wand, there's no magic money tree that's going to fix that overnight, but at least if we can negotiate some kind of a reduction in that funding gap over a number of years, then we will have done well. But we are working very hard behind the scenes, and our colleagues are having to deliver against all of the expectations that every system around the country is having to deliver with far less money per head of population than we should expect. So, tough times, but thank you to all the work that you're doing behind the scenes for trying to address those issues and those gaps. Let's move on then to board item number 10, which is the Board Assurance Framework. Catherine.
Thank you. So, as with other presenters, I'll assume the paper's been read and just wanted to make a few comments in introduction. So this is the continued journey we're on as an organisation and a board to develop our board assurance framework corporate risk register. So it will always come over as being still work in progress, but it's about taking a stepwise approach. I think as we've discussed before and we picked up at the workshop, the straightforward way of doing this is having your agreed strategy as an organisation and your strategic objectives, and then determining the key risks to delivery of these, and they would be the risks that were included in the board assurance framework. As our next two papers will show, we're still in development of our overall integrated care strategy and our organisational response, so we don't have those individually owned strategic objectives. So as we've discussed before, we've been using the 4 overarching goals of ICSs to frame our strategic risks. The view is this probably won't change the risks that we're facing, but as we develop our own strategic objectives, it will be a bit dynamic, and we'll need to change the structure in which they're reported. So if you take it in that context, and again, as we've discussed, the executive reviewed other more mature integrated care boards to look at their corporate risks, reviewed what CCGs had before and what our teams and directorates had been generating or reviewed as risks to delivery of their work, which has identified the 8 key risks to delivery of our overall purpose that are identified in this paper. We had some conversation about that at the board workshop in slightly tweaked in light of that, but will continue to develop, and then the audit committee reviewed it at their meeting earlier this month, and so the audit committee are, as a first step in our journey, recommending approval of these risks to the board, and also asking you to note the progress that we are making on developing this, and then assuming agreement or tweaking an agreement, it will be presented in a board assurance framework at the next meeting.
Thank you very much. Inviting comments. It's a work in progress, but any feedback would be helpful. Nick?
Catherine, thank you for this. Just 3 comments from me. Firstly, I just wonder whether the wording in relation to the people organisational development risk rather underplays the risks associated with our workforce. I think it extends beyond missing opportunities. Secondly, is there a risk associated with the development of this group, the ICB, not least that we're out to advert for 5 executive appointments? So I'd have thought that we need to sort of highlight the need to develop the board as a risk and the key role the board plays in leading the system. And thirdly, I'm really keen that we include something that reflects the need for us to fully engage the research and innovation capability that exists within the system. And I think there's a risk that we won't harness the academic power of our universities, etc., to drive forward transformation.
Excellent points. Thank you. Anyone else? Steve?
Catherine, it doesn't necessarily jump out from the paper, and maybe not necessarily it should do, but it'd be useful just to expand how we see the use of the board subcommittees in relation to the sort of BAF and the corporate risk register, in terms of some of the board subcommittees being aligned to or owning some of the BAF headlines and the corporate risk register areas. Obviously, audit and risk take a broad overview, but getting a wider sense of the subcommittees in general's oversight of our risks and the BAF would be helpful.
Yeah? Making a note? Aidan?
Yeah, I mean, just per your comments on the last agenda item about the resourcing position, and I'm looking at health inequality specifically, maybe we should draw a more explicit line between the two there, rather than just talking about resourcing appropriately, and recognise that there is a significant risk to our ability to tackle health inequality, while our resourcing position at national level is undermined by the variance away from what we should be funded at. I'm sure we can find a more eloquent way of describing it than I just stumbled out, but something I think that draws a more explicit line between the two.
Yeah, great point. Anyone else? So there's some helpful nudges and feedback. My general comment would be, and it kind of blends those comments there, is that some of the language here, I think, is maybe designed to be gentle and a bit soft. And actually, risk registers are not meant to be that. They're meant to tell you, talking straight to you about this is what will happen if we don't do X, Y, Z. And there is some of that in there, but in some it isn't. So I would sharpen some of that up a bit as well. And then I would add that, I don't know if it's within one of the boxes or separate, that something around equalities, diversity and inclusion. If we don't get that right, we say we're committed to that. What are the implications if we don't deliver it? If you could have a think about that as well, please, on top of everything else that we've heard. Is that helpful?
Yes, thank you, very helpful. So this will inform the next iteration, and they'll be reflected at our March board meeting and through committees beforehand.
Yeah, the committees bit is really important.
Yeah, I mean,
the detailed interrogation.
It doesn't come through very strongly, but the lead committee for each of the overarching risks is highlighted in the table.
Yes.
In the annex, along with the lead executive.
Yeah, very good. Really pleased to see transformation under the Chief Executive Officer. That's exactly where it should be. That small challenge. Yeah, great. Thank you very much. Time for a comfort break. We're doing well for time, so 10 minutes, please. Thank you. The draft integrated care strategy and the ICB response. Rob.
Thank you, Chair. Catherine and I are going to do a bit of a double act on this one, so I'll just give it a little bit of an update in terms of where we are with the strategy process, and then Catherine's going to do a little bit in terms of the ICB response. So again, just to recap where we are, the integrated care strategy through last autumn, a draft was developed collaboratively with partner organisations from across the whole of the system. The integrated care strategy is something that is developed on behalf of the integrated care partnership. So it is something that is for all of the partners across the system, of which we are one. And the draft was developed and published on the 13th of December for a period of public engagement. The draft itself sets out a number of priorities that are proposing a direction for the system. And through the period of engagement that we've got, we are seeking response and feedback from both the public and from our partner organisations. The ICB has taken on a role of sort of leading and coordinating that engagement period, but that is something that we are doing again on behalf of the Integrated Care Partnership. So within the paper there are a number of sort of sessions that we've got set out. Again, we are seeking and encouraging feedback from members of the public, and we're attending the meetings that we've got here. I think important to note is that we have next week set out a number of sort of open public events. So if there are members of the public that would be interested in attending those and providing their feedback through that particular channel, there's an opportunity to do that. Catherine, are you happy just to provide a little bit of feedback in terms of how we as an ICB might be responding?
Yes, so it's one of these that, first of all, we have said we would like to submit a response as an organisation, but that is in the context of us being one of the statutory members of the partnership, and therefore will be one of the organisations that agree the overall strategy. So we talked at our workshop about focusing it on how we intend to reflect it in our delivery plans, and then highlighting any major omissions or concerns that we see from our points. So what you have in paragraph 9 is a set of bullet points of some of the areas that you raised as board members when we talked about it on the 20th of December. So it's here today to see if that does reflect the conversation we have, if there is anything else you want to add, but also then to ask you to delegate authority for signing it off to the executive when we meet next week, so that we can reflect any comments made today.
Okay.
Good, thank you, Catherine. So it would be helpful to have a discussion about that, but the engagement period will close on the 29th of January. The ICP will meet on the 27th of January, and there will be some indicative feedback that we will provide to the ICP, noting that the engagement period won't actually have finished at that point. Rob and colleagues are producing a report that will summarise the engagement, and that again is something that we will share with the ICP, and then the proposal is that through February we're making any changes that we need to make to reflect feedback that we've received, with a view to that strategy going to the ICP meeting that is scheduled for the 1st of March, hopefully to be signed off at that point, and then can be made public shortly afterwards. So in terms of the ask of the board, I think it's really to reflect on the feedback that was captured from our last meeting, and to understand if there are other things that need to be sort of fed in through that engagement process.
Okay, so and that's paragraph 9, those 7 bullets. Yeah, so the question there for us today is, does that accurately reflect what we said to you last time we discussed this?
And this is any more.
Yeah, and anything in addition. So is that clear? Is that, yeah, if you look at paragraph 9, then let's try and think about that. How well does that capture what we said last time? Anybody, any thoughts? Aidan?
I think it does. I think maybe the words health and inequality maybe need to be in there more explicitly, just so that there's no ambiguity about our focus on them, and also just reflecting Javed's earlier comments about diversity as well. Maybe they need to be there. But yeah, no, I think they do. I think the overall comment, Chair, really was in a very complex world to try and strive for simplicity and that golden thread that runs through what we're trying to achieve. You know, the more and broader group of stakeholders who can participate in and understand what we're trying to communicate has got to be a good thing. And it's not easy. It's not easy because there are so many different masters that we have to serve in terms of bits of information. But I think we've captured reasonably well there what we're trying to achieve.
Thank you. Any other offers? Neil? No? Mr. Twitch? Nick?
Can I just pick up the point of engagement? I know it's very short notice, but I notice you're going to Neil's board next week. You're very welcome to come to ours on Wednesday. I know it's a great offer. I know it's a great offer. It doesn't get much more exciting than this.
If that would be something that's helpful to do,
Well,
happy to
just in terms of broadening the engagement, and I'll link you to Kerry, who's our board secretary.
You're showing great excitement at that offer, Rob. Yeah, it's capacity, I'm sure, nothing else.
It's online as well, so you can do it from home.
Stephen?
Thank you, Chair. And, so I think this is a really great piece of work, and the engagement so far has been excellent. So well done in that context. One of the questions I have, and it's not specific to this strategy, but it relates to any strategies that are developed, is quite simply, how are we going to ensure that the resources needed to implement those strategies are prioritised? And I'm not thinking these being solely NHS resources, because clearly there'll be resources that are currently being used in local authorities as well as in NHS, and maybe new resources that are going to be needed. So in a way, it's the principle of, as we develop a strategy, whether it's a place-based strategy or an ICS or an ICB strategy, how do we ensure we're clear the resources needed are identified and prioritised from the outset? Otherwise, I do risk we're going to have a number of really good strategies that have been co-produced and then struggling to implement because we've not agreed how we're going to resource them. And that's as big a challenge for me representing the local government as it is for the NHS.
Shall I start that and then hand over to Jim, who will probably have a better answer? So I think it's really important for this particular agenda item that we recognise that this is an ICP strategy. So as you rightly say, this is something that we need to make sure we think is realistic when the Integrated Care Partnership as a group meet on the 27th. And then there is joint responsibility for all of the partners who are there and representing this as an ambition, all collectively own that. I think for us as an ICB, so representing the sort of NHS side of this, the next agenda item I think starts to answer some of that, but as we get into the delivery planning, it is absolutely a challenge that we need to be clear about the plans that we're putting in place are realistic in terms of the capacity and capabilities that we've got across the system, but also recognising some of the constraints that we've got. We've got detail that will come through from Matthew when we're talking about the operational plan, because that reflects year one and some of the ambition that we need to be responding to nationally, but also recognising that that is year one of delivery of the strategy. So we need to make all of those things tie together. Year two, we start to get a bit of an indication of what some of the financial environment might be for year two. But again, as we look at the joint forward plan and the NHS plan that we're developing there, we do need to be making sure that what we're saying is realistic. Jim, there's probably a more articulate version of that.
So I think this is inherent in all strategies. You never have a fully costed strategy, because that isn't what strategies, I don't think, are about. I do think what we do need to understand in the strategy, though, is what some of the financial constraints might be, and what some of the decisions that we might have to take in terms of making sure that that general direction of travel and the strategic direction we want to deliver. It's impossible to do that because up until this year, we only ever used to get allocations for 1 year at a time. This year, we've had a 2-year allocation, but it would be difficult to do any detailed planning, even on year 2's allocation, based on the level of detail that we've received. I think the key to it is, as Rob said, that as we develop our first year plan, a delivery plan of that strategy, we will have to review that direction in terms of the speed of travel of that direction because of the financial constraints. I think one of the issues that we probably do need to take away, though, is whether or not one of the things that we want to do as we go through that planning process is whether we want to create some specific resource for transformation and moving the service forward.
I think you've delved into the next agenda item, really, rather than the one we're currently on, which is the integrated care strategy, and our view on that, isn't it? But I see how you were led down that path. But we'll come back to that. Steve?
No, because I'm probably going to...
You're going to do the same, will you?
Unhelpfully, in terms of, I suppose, a specific example falling out of the ICB strategy. But I don't want to take us down that if you want to guess.
We can come back to that on the next items when we talk about ICB bit. But specifically on, the question was additional feedback, sort of little nudges we can give to Rob and Catherine as from our point of view. Have we covered everything? Is everything there? Okay. So what I've heard so far is we need to dial up some of the language, perhaps which isn't quite picked up here, around health, inequalities, diversity. The overarching one I would like to see more of is integrated health and care. I mean, that's what it's really about, and we all want that. And building on Stephen's very helpful comment, I mean, it's great to hear a local authority chief executive being so bold and talking about, well, how do we come together and potentially pool resources to make some of this happen. I think that's going to be the real litmus test, isn't it? Of genuine, we talk about partnership and collaboration, but if we can't actually bring our joint resources to the table to redress some of this, then how real is it going to be? So from an ICB point of view, I think it's good for us to feed that back in. On the specifically on the second bullet, under paragraph 9, the second sentence, it says, this led to the reflection that statutory services are not the right organisation to deliver X, Y, Z. I don't think we actually said that. I think maybe, from my memory, a more accurate reflection would be led to the reflection that statutory services alone cannot deliver the X, Y, Z. So it's the need to work interdependently with the voluntary and community sector and other partners, I think, was the message. Yeah, I see a few nods, so I didn't dream that. Rob?
Could I just clarify the inequalities and EDI point that we're trying to make, because we need that. This is something that ideally we are asking as a board to be considered as part of feedback into that process. So the strategy, I think, the proposed draft strategy sets out very clearly an ambition for a really strong push to tackle inequalities. and it will do that by looking at all of the inequalities that we've got across the system. Are we saying that there's something that are we just strongly endorsing that, or is there another point that we're trying to make?
I think the point was these 7 bullet points don't say much about that.
But what is it that we're trying to say that is the feedback to the strategy?
Steve,
I suppose I'll have a go at that. So I think it's kind of the connection between the first bullet point there and the kind of so what. So we can make statements about health inequalities. We have a significant amount of data. The work that's coming through the ICP strategy should be data-led. It should be building on the existing health and wellbeing kind of board priorities kind of at place, which again should be data-led. So when we're talking, when we're starting to articulate in the ICP strategy, I think what we're saying is we would like to see that drawn out in some specifics. So if under starting well, there is some clear evidence around significant health inequalities for certain young people in our population, actually let's describe that in more detail. The statement we want to improve health inequalities is relatively meaningless. So I think it's about amplifying that into the specifics where the data is relevant to that.
Yeah. Does that help?
Absolutely.
Yeah, I think it's a very good way of putting it, Steve. Okay, Tim.
Yeah, I mean, it's probably a bit late in the process to be saying this, but having read the thing again over the last few days, and we've got our key sections and we've got our 18 priorities, the one thing that didn't leap out, and maybe it's sort of in there, but is about innovation, new ways of working. And I get that as part, but I think if we don't explicitly say it's part of our strategy to actively investigate those things and promote those things, and I know that they're not an end in themselves. I understand that what matters is the 18 things about improving mental health, improving specific. I get that. But I think if we don't explicitly tease out, and it sort of goes back to Nick's point on the previous agenda item about risks, if we're not, I think, given where we're situated and the resources we have in this system, I think we should be a strategic priority for us to maximise innovation and new ways of working for the benefit of our population's health explicitly, because it's probably an enabler to many of the 18 priorities, but it's not explicit. And I think we are uniquely positioned with the resources we have, and I think we should see it as a priority to maximise the use of innovation for the benefit of the population. And I don't know how you want to put that in the feedback, but and I know it's just one person's view, but I feel we should tease it out.
A few nods around the table as well, so thank you. Good nudge. Yep, is that helpful? Okay, great. We'll wait to hear more on how the meeting on the 27th will go as well, where this will be discussed in more detail. Thank you. Before we move on, I should welcome an additional member, not of the public, but of our host organisation. Councillor Angela Macpherson has joined us, who's Deputy Leader of Buckinghamshire Council. Thank you for allowing us to use your premises today, Councillor. And thank you for joining us as well. And also is a member of the Integrated Care Partnership. Rob, take us on to the next agenda then, which is the 5-year forward plan.
So the next agenda item is looking at the 5-year, the joint forward plan. And I think it's important to try and draw the connection between the 3 items that we've got in this section. So we've got the integrated care strategy, which is setting the direction. We've got the joint forward plan, which is setting a 5-year delivery ambition for the NHS. And then Matthew's going to talk about the operational plan, which is kind of year 1 of that process. So these 3 things that we should see a clear link as we're going through. What I wanted to do here is very briefly explain the guidance that was published and some of the timescales that we're working to, and then at a pretty high level the approach that we're proposing to work through to develop some of that plan detail and some of the next steps that we've got planned. So there are a few things that I will pull out from the paper that was circulated in advance. So the first thing is the timescales. So we previously were working to an assumption that we needed to have a very final version of the joint forward plan published by the 31st of March. One of the challenges that we had within the development timescale was there was a significant requirement for engagement, which is something that we've said that we want to do as comprehensively as we can. The requirement now is that we publish a final version on the 30th of June, so we've got an additional 3 months. But it's really clear that that 3 months is really specifically for some of those mandated engagement activities that we'll need to partake in. So there's still the primary effort to develop this plan is by the 30th of March. In terms of the purpose of the joint forward plan, I've said a little bit about this already, but within the guidance that we've received, really there are two things that we're asked to do. One is about set out how the healthcare organisations that are responsible for developing the joint forward plan, how they will deliver the ambitions that are set out in the integrated care strategy. So it very clearly has to be an articulation of that delivery plan. The second is a sort of a broader requirement, which is setting out a delivery plan for how we will deliver the universal commitments of the NHS, the universal NHS commitments. So we're trying to balance those two things, but we'll be using the structure of the integrated care strategy to be able to tell that story, recognising that that's the thing that is of local importance to us that we are delivering. The guidance also helpfully sets out some expectations around engagement, and I think it's helpful for us to recognise those things here. So the expectation is that this is a plan that is jointly owned between the ICB, but also with the NHS Trust partners that we have across the system. So this is not just an ICB plan, this is a joint plan between the ICB and the partner trusts. However, the expectation is that there will continue to be system-wide engagement in the development of some of the content as we go through. So we are proposing that there'll be a number of sessions where we can do that, focused around specific areas. In terms of specific roles that we need to bear in mind as we're going through this, the guidance refers to a supporting role that NHS England will play. Very clearly says that is not an assurance role, but it is a support role. And I think the second formal role that we need to recognise recognises the importance of sort of the partnership element of this, and the need to work closely with health and wellbeing boards. So we have our 5 health and wellbeing boards that we will need to be working closely with. Health and wellbeing boards will be given an opportunity between March and June to provide a formal opinion on how well the joint forward plan will support delivery of the local health and wellbeing strategies. So that's something that we will need to build into the planning. We've started that conversation with the Health and Wellbeing Board coordinators last week, and we'll need to sort of consider within the plans. But linking that to the priorities of the strategy and making sure that we are delivering the priorities of the strategy that we've just spoken about is really the important thing that we're doing there. I've put a little bit in the paper about how we're proposing to develop the joint forward plan, and really the proposal is that we're doing that a bit of bottom up and a bit of top down. So we've asked the ICB sort of service area leads to take responsibility for working across their networks within the system providers to pull together a service level ambition for 5 years, That's very closely going to tie in with the requirements that Matthew will talk about in terms of year one for the operational plan. We also recognise that there are a number of areas that are either very big or very complex, or potentially things that we're trying to do that are new, and we're in the process of trying to coordinate a number of sort of service-specific workshops that will try to get into a bit more detail about what some of those particular ambitions for those services will be. So Nick and I have talked about how we'll tackle mental health and potentially try to link in with the development of the mental health provider collaborative and how we engage them in that process. I think I'll pause there for questions, comments.
Okay. Thank you. There was a lot packed into that, and a very helpful report. Could I perhaps focus people's attention to what Rob referred to, which is paragraph 11, the principles underpinning the joint forward plan development, those three principles, and perhaps whether we agree with that. Is that a sensible foundation, for example, or any other aspect of the report?
Shall I say how we're interpreting those? So very simply, principle one, about aligning with the system partnerships ambition. So that we are saying, we're interpreting as how is the joint forward plan going to articulate a delivery, the NHS delivery plan for the integrated care strategy. So we're going to very closely align what we're saying to the integrated care strategy structure and ambition. Principle two is around subsidiarity, and all the way through this narrative, we are expecting the place story to be clear. There will be some sort of upfront ambition about how we are expecting both the place-based partnership and the provider collaborative, sort of what their journey will look like over the 5 years, recognising that some of that is still in development. And principle three is, I think, just a principle that this is a plan. It's not another strategy, so this is a plan. And so there needs to be sufficient detail in there that sets out what we will be doing when. I guess my caveat with that one is we're describing sort of the provision of NHS services across a significant geography, so we need to be realistic about the level of detail that we can get to there. But it does need to be a plan.
Okay. And we should include within this the comments, Jim, that you made earlier around the practicalities of the financing of this. Yeah. Okay. And Steve, you were going to come in earlier. You want to come in now? Is that helpful?
Yeah, I to keep, and we've said it a number of times, it's really important that we keep drawing back to that kind of golden thread, as Rob's alluded to and others have, of that connection, ICP strategy, kind of trying to be as focused in terms of those strategic ambitions as we can as part of the ICP members, with our kind of wider engagement inputting into that. You know, the 5-year kind of forward plan then translating obviously into year one, year two, certainly in terms of the sort of NHS funding allocation. But I suppose an example of that may well be if you know, if we get to a point that, you know, one of the ambitions under something like starting well within the ICP strategy is to significantly reduce childhood obesity, and where that is potentially more prevalent in certain parts of our kind of population and different parts of our communities, then, you know, to Stephen's point, actually that there needs to be a collective response, you know, across local government and health in terms of the distribution of resources over a 5-year period to actually move that dial. I think we've got to be really careful when we get into that space not to see, oh, well, we can improve our position on childhood obesity if actually above core funding we get more money. There's got to be some really difficult conversations about, if that's a priority, how are we going to disproportionately resource that over the next 5 years, which may mean a different distribution of resource into local government, where actually there's those touch points, or within public health, where there's those touch points, or in mental health services and primary care services, to deliver that over a 5-year period, and less elsewhere. And I think that's, to Stephen's point, that's where we've got to get into some of those sort of challenging conversations. And then, we're looking, as we'll come on to, the sort of planning guidance for next year and the financial allocations for the next 2 years. Well, what does that already say about the financial environment in the NHS currently, to connect with some of the ICB strategies that we will see emerge and published in the next month or two. So I think that's where it's going to really get into some really important partnerships and integration conversations, because it can't be we can deliver these ambitions if we just get more.
Yeah, totally agree. Yeah, Aidan.
Yeah, one of the things that we on the Place and System Development Committee want to do is use that as a vehicle for kind of drawing macro strategy into place and putting it into the context of place, and really kind of deep diving into where the kind of reality of some of the objectives that we've set out at Bob level actually happen in Buckinghamshire and Oxfordshire and Berkshire West as well. So we'll be really keen to kind of draw some of this into that context, and to ensure that we're not taking a kind of generic Bob wide view of everything, but actually drawing things down into what's the reality that's on the ground in different places. What are the particular challenges, and as Steve's alluded to, what are the kind of more nuanced responses that we need to undertake in different places across the patch. Not just asking for more money, by the way, although we, no promises on that one, but actually more kind of bringing that more specific, more bespoke, more place-centric response, I think, into some of this. This is, which is really, really good, and I think will be a kind of helpful two-way flow of information, actually, as we start to get into our stride.
Great, thank you.
Can I just quickly respond to that? I think so that's helpful, Aidan, and I think part of the challenge that we have this year is that we're developing both the sort of the detailed place plans together with some of this, and we're doing that in parallel. The assumption is that in future years, actually quite a lot of the joint forward plan will be place-led. So it's a particular challenge to kind of get that nuance right this year, but hopefully once the place plans are clearer, it will be easier.
Nick.
Thank you. I suppose I should come at this from a slightly different angle, and as some colleagues will be aware, I'm not particularly wedded to the subsidiarity principle, and I would be worried if that is interpreted in a way which means that we overlook some of the potential benefits from harmonisation, standardisation of services, and indeed economies of scale. So I just would like that sort of just in the back of people's minds. I don't think the aim of this system is to be a loose confederation of 3 strong places. I think we're trying to achieve something rather different to that.
That's a significant challenge to the way that some people are thinking about this. Perhaps
I think it's a challenge based on the fact that we are in such a difficult situation. I do think we need to be radical and transformational in our thinking, and we do need to look at how we use the limited resources we have differently and more effectively, and I think to do that we need to look at pooling resource, and we certainly need to ensure that we don't have unwarranted variation in service delivery that's not based on clinical need, but based rather on historic commissioning decisions which perhaps were not as evidence-based as they might have been.
Do you think the two views or approaches are mutually exclusive necessarily?
I would like to think that we can find the Goldilocks zone. So yeah, it's a different approach, but that there will be a sweet spot, and I think it's incumbent on us as the leadership of the system to try and find that sweet spot.
Yes. And that's why the paper that's promised to us in March around place and the future of place and what it will actually look like, I think will be quite key in helping us get to that sweet spot as you describe it. Because I'd like to think, that I am committed to subsidiarity from my point of view, but I wouldn't want to argue against what you just said, because I think there are many other benefits that we could deliver in other ways too. And one should not exclude the other. But we need a thorough interrogation of what those opportunities are and make sure we're not, that simply going down place doesn't make it more difficult to deliver some of those things that could be obvious. But getting there is the real challenge. Tim?
I think it's a really interesting challenge from Nick, and I think it's about not being dogmatic.
Yeah,
and it's not, I know these are cliches, but one size doesn't fit all. So there are certain things that are clearly done better collectively. It's a non-clinical thing, but you might say procurement might be one of them, where there's just common sense that a lot of that should be done system-wide, not even sort of county-wide. But there are other things that are clearly done better at a local level, and I think Aidan's committee is going to be central in this, in deciding when it's best to go local and when it's best not to. And we shouldn't, while we may have a desire to ultimately devolve power to the people as much as we can as a prince, it's not in all cases on everything at all times. I think it's what's best for the residents and patients of the area on a case-by-case basis. And I think it's a good challenge. It's not, local is not always best, but certainly system-wide is not always best. It's
yes.
What's the topic, what's the benefit, and what's the objective?
Stephen, and then Jim.
Yeah, thank you. Nick probably thought I'm about to respond to his point. I think, in a way, my response has been made by others. I think you have to look at the argument for decisions on a case-by-case basis. I differ from Nick, but I don't think I do in a way, because I do want 3 strong places. But then if you have 3 strong places, you then have a strong system in a way. The point I wanted to make, though, before Nick prompted me to go down that rabbit hole, was so colleagues on the board know I am a glass half full individual. Yet when I read the guidance around developing joint plans, I held my head in horror. It talked about developing a joint plan, and I thought, great, that's a joint plan between the NHS and local government. Oh, no. It's between the commissioner and the provider in the NHS, with some reference to the role of partners, explicitly local government. So in a way, you could read the joint planning guidance from a local authority point of view and say, that's got no relevance to me or no impact upon me. It's primarily an NHS element. But if you take our earlier conversation around how a lot of money is now coming very clearly down a route that requires us to work together, and our discussion about wanting to do long-term commissioning around discharge support, for example, or alternatives to CHC, we need to do that together. So in a way, we have to avoid reading the joint planning guidance and following it religiously, because it will limit the potential for us to do some of the things we need to do and would want to do. Because when you look at some of our performance, the number of people with learning disabilities that are in intensive treatment units that need to be supported back, you can't do that without engagement of local authorities. You take discharge from hospitals, you can't do that. So you take, I don't know who used the example about reducing childhood obesity. You cannot do any of that without looking at it from a system point of view. Whether it's a place or a system, it's irrelevant. So my challenge or my ask of us is to ensure we're not limited by the guidance, that we start with the guidance, but we then build upon it where we've seen opportunities and requirements. And do it together, because there's nothing worse than, and I know we will avoid this, but please do not come to a local authority and say, what are you doing around helping us deliver our assessment and treatment discharge plans for people with learning disabilities that we've not been engaged with, So disappointing, but we didn't write the guidance, so we can avoid owning it in that respect. But we've started from a good point about let's not do anything that risks creating a problem for another part of the sector. We've got some really good opportunities coming alive through integration. Let's ensure we're building those into our plans as we move forward.
Thank you, very helpful. And Rob can speak for himself, but as you were speaking, I'm just looking at paragraph 12. It talks about developing joint forward plan collaboratively, and then you look at the bullets down there. That is quite an ambitious engagement approach that Rob set out, which of course includes local authorities, health and wellbeing boards, and everybody else. So we have to make that real, is your point. You know, if we were to produce a joint forward plan and not involve all of those people, then let's not be surprised when the problem happens and we go knocking on your door. And, Jim and Tim.
I suppose for me there's something about language that we're using in terms of subsidiarity and primacy. Actually, if we are going to deliver and make the best use of resources and deliver the most, there will be some things that are best done at place. There will be some things that are best done at an ICS level, and there will be some things that will be in the middle. And I think what we've got to do is be really clear where each of the things that we want to do sits on that spectrum. And rather than talking about one place being more important or other place, actually, it's all got to gel and work closely together if we're going to deliver.
So it's the proverbial Venn diagram.
Yeah.
That's what you meant, didn't you? Yeah. Tim.
Just Stephen's point was worrying to hear, but good to hear, in that I think it needs to be said. My understanding was this is the NHS part of the delivery plan. It's not the, obviously we need the local authorities and the VCSC, everybody together to be pulling together. I read paragraph 23, which I just want to clarify then in light of what Stephen said. It talks about, in terms of delivering the plan, relevant cross-system strategy working groups will be convened now, basically, or soon. Do those include local authority representatives, or is that NHS-only working groups?
So when I wrote this paper, I was referring to the strategy working groups that we had to develop the strategy. So they were pan-system with representatives from local authorities and health and wellbeing boards, but also voluntary sector, NHS partners.
So I understood here's the plan. I know it's not 100% signed off yet, I get that, but it's broadly agreed. And I thought those were the groups that were then going to go off and put specific targets, specific action plans in place. Is that not correct?
So what I am proposing has sort of shifted a little bit from when I wrote this paper. So I think those strategy working groups absolutely have a place, because that's about tying the ambition that we're going to put in the joint forward plan back directly to what has been developed by the people that developed it with those groups. So I think there is still a place for how we use those groups.
Yeah.
However, I think as we get further into the detail of how we're going to develop and set a sort of delivery ambition for some of our more complex areas, I think the conversations that we need to have should be more specific. So rather than about live well, just to keep going on the mental health example, if we want to set a delivery plan for mental health, we should be doing that with a mental health provider collaborative, but we should be doing that sort of openly, getting the views of other stakeholders into that conversation as well. I think the challenge that we've got is that there's a huge amount of ambition in a relatively short amount of time. So part of this is about putting flags in the sand to saying, here are some things that here are some challenges that we need to solve, and here's an approach about how we're going to solve it, which I think should be setting out actually how we are proposing to do that collaboratively with our kind of wider system.
Because I read that paragraph, because it's under the heading of delivering the plan, not creating the plan or consulting on the plan. I read that as an assumption. The plan, I know it isn't yet, but once the plan is locked and loaded, there's then teams of people who are going to turn the strategy and the plan. So strategy is turned into this plan, and then this plan will be turned into concrete action and work and activity that's going to deliver the benefits we all want. And I read that as being the start of that process, where I assumed we were going to call on the relevant voluntary groups, the relevant local authority people, the relevant NHS people, and those teams, which will be different in every case, will crack on and do the work, set the targets, come up with the action plans, owners of actions, That's what I thought that bit was. It sounds like I'm perhaps a step further down the road.
You're a
than I
step
should
further
be.
down. You're a step further down the road.
Okay,
So
all
the
right.
plan should set out how that's going to happen.
Okay.
Okay. Matthew?
I think
We need to get on with it, because otherwise the first...
Yeah, okay. Matthew?
So I think with just my observation, it's important that we use the architecture we're setting up in terms of collaborative working and partnership working to deliver this strategy. So place-based partnerships will be where we do some of that. Provider collaboratives will be where we do the delivery. I don't think there's a new, different architecture that's going to deliver this strategy. This is about establishing the joint forward plan through a collaborative model. But we've got to create the partnership architecture that delivers. So that's my observation on your comment.
You've had three goes already. That's it. That's enough. Message received. Okay. Anybody else who hasn't had a chance to speak on this particular agenda? Lots of really interesting challenges and philosophical challenges as well, I think, about where is the pendulum, where should the pendulum stop swinging with, place-based versus, and all that subsidiarity stuff, commitment versus system-wide, and let's not lose the benefits of either along that journey. I mean, that's a really good conversation point, I think, for the board to pick up again, and perhaps a number of times before we get a collective view on this. But good challenge for you, Rob, so with support from everybody else. Can I just throw one other thought in? That one of the things I really hope that this, the ICB version of the thinking is going to offer is a real sense of the degree of innovation that we can bring to the table, and how the world may look very different in 5 years' time. It's a 5-year joint forward plan, and recognising the challenges of getting the first year's operational delivery in place, which is probably not going to look that much different from where we currently are for practical reasons. But if we can't set out a clear, ambitious vision for where it's headed to in 5 years' time, then we may have missed a real opportunity. And how do we get that inserted in there within the few months that we've got? It isn't a lot of time. And there's some of the things that have arisen in these board meetings before around the opportunities that we've got on our patch in particular. We've got some of the most brilliant brains in the world who reside within Bob. How do we capture their imaginations to think about a forward plan for how health services can be delivered in an integrated way? Robotics, automation, predictive analytics, all that kind of stuff. Are we going to be able to capture that within these months? It's the challenge. Steve, have you done it already?
Yes, obviously. So it's probably just worth saying that our responsibility will be to develop a annual refresh of this, and therefore it becomes a rolling kind of 5-year plan. So I think let's just have in our mind that we haven't just got one bite at this in the next couple of months, and if we haven't got all of that in, then kind of we haven't done what we said. So we need to unfold this appropriately in terms of the delivery plan into 23-24 in response to the ICP strategy, in partnership with our partners, recognising that spectrum that Jim alluded to in terms of where the magic happens, at aggregate, in place, etc. And we need to ensure that we're also capturing and building in for the next iteration on a rolling basis. So I think just have that in our mind that it isn't. It's an important starting point to get this right, and it becomes iterative because of our responsibility to kind of update this on an annual basis and continue to engage and develop that with partners.
Thank you. It's a really helpful reminder. Yeah. Okay. Shall we move on? Thank you. On to the operational plan then for the next 12 months. Matthew.
So no, it's a really nice link to build a similar conversation in terms of the strategy, the joint forward plan, and the operational priorities. So this paper highlights the NHS operational planning guidance, but I would say that when we look at the metrics and take comments, that the vast majority of these are not deliverable by the NHS working in isolation, but actually are fundamental to our integration and partnership working agenda. So there are 3 key tasks for us in terms of the national position. That's to carry on to recover our services and productivity. So we obviously saw some challenges through the pandemic, which are still with us as a system, and we need to carry on focusing recovery, some of those core services. in terms of some of the financial challenges as well, we've got to continue to focus on productivity. Reference back to the NHS long-term plan and making some progress towards some of those long-term ambitions and continuing to transform the NHS to the future. So the guidance tries to set out really what progress nationally is expected to be made next year, which is a challenge. And what the paper tries to do, and I'm not going to go through the detail, I think much more helpful to have a debate, is give a sense of what the target is for next year and where the system presently sits against it. So you've got a feel for perhaps some of the challenges and the size of the challenge that we face next year. But it's important, I'm sure that Jim will come in at some point before we finish this debate, but obviously these delivery metrics have to be balanced with a number of constraints. So the financial envelopes that we've been given for the next 2 years, the workforce constraints and initiatives that we operate within, and the level of digital transformation possible as well. And so you'll see the guidance make reference to all of those enablers in terms of next steps. But just a couple of examples, perhaps to bring out the flavour of it. So if we look at, we spent a lot of time, quite rightly, talking about urgent emergency care this morning. So there is a clear target next year for recovery of our A&E 4-hour performance, which is 76% as a target. So that's against an average of about 60% that we've been running as a system for the last few months through these challenging periods. So it's difficult to get a flavour for that, but if you think if we're really going to achieve that, we've probably got to crack quite a lot of the discussions we've had around discharges across the board this morning, and we're going to have to invest and develop that. So that goes back to Steve's point around making sure that we really make best use of the additional discharge money that's been put in the system across health and social care. And so whilst we may have a specific target, there is a lot behind that in terms of what we need to unwrap to deliver. I'd make the same point about occupancy rates as well. So there's a clear occupancy target going into next year that is below our present operating model and well above national best practice in this space. So again, that really goes to the heart of how we operate as a system with all our partners in trying to release some of that capacity in the system. Just a couple more examples, and then perhaps open it up for questions. So pace of recovery, pace of elective recovery is really important. So I mentioned in the performance report that we're making good progress in reducing our long waits. So the ambition set nationally next year is to remove those waiting over 65 weeks, which is, we'll all have a different view on the reasonableness of that as a target in terms of speed, in terms of that additional activity and making sure that we reduce the waits in the system. There is a slightly different contracting mechanism to support that, so we're going more back to a payment by results model in terms of elective activity, and there are some particular financial mechanisms that Jim may refer to try and incentivise that across the system. If we think of the golden thread that we've been discussing between the ICP strategy and the joint forward plan, some of the items I've already mentioned are in both, which is great, but also there is a focus in the operational planning guidance around health inequalities as well, and prevention. And you'll see the reference there that Rachel and the team have made to the health inequalities programme we have in place and how that aligns with that. So in one sense, it's helpful to have the extent of the ambition, and we need to do some work on triangulating those ambitions in terms of targets with the financial allocations for the workforce availability and the digital next steps, and that's the job of work we need to do over the next few weeks. And it will be a challenge, but I'm sure one that as a team and as a system we're up for to try and distinguish that. But we also need to remember that we need to build into this our local priorities. So again, that goes back to the piece around the ICP strategy, the joint forward plan. So there will be a lot of alignment in these with what we want to do locally, but there will be areas where we want to change the focus and perhaps might want to even challenge that delivery target for next year because we've got a slightly different perspective locally. And to go back to the place debate, all these targets and performance issues will be differential by place, and the challenges will be differential by place. So as we go through this as an ICB, we'll need to be cognizant of those differential challenges and think strategically how we might address those in terms of our resource allocation and priorities for next year. There's a little bit about process and next steps in there, Javelin board members. Hopefully that's clear in terms of how we're progressing that. We'll be taking a lot through the Productivity Committee in terms of progress over the next couple of months before we come back with a plan at the March board. I think I'll leave it there as Tom to an overview. Happy to take questions or comments. Jim,
Thank you very much. A lot packed in there, and in your report in particular as well. So, Jim, can you add to that?
Would it be useful if I give a little bit of the financial context as well going forward? So I think...
as long as there's some good news in there.
No. So I think there's... well, it is good news in terms of the uplift was 5.29% growth. We have had 0.2% convergence to recognise our difference from target funding. It still leaves us quite a considerable long way short. The second thing that probably we just need to bear in mind is that it will be exceptionally challenging next financial year. We've heard today already that we have got planning to deliver a 44 million deficit across the ICS. That will have to start to be addressed in the next financial year. The inflation assumptions are going to be challenging. I think everybody's aware that the costs are increasing dramatically, and there are some assumptions that are in there in terms of the overall funding for inflation. We have reduced and lost some COVID monies nationally. That's a strategic plan that's there. And we will have to still deliver on efficiency. So it is going to be quite a significant challenge financially next year. And we will be working to identify those areas where we've got options that we need to decide how we utilise that money. Because within the overall allocation, there are increases, quite rightly, for the mental health investment standard, for primary care, which are over and above the level of growth, which does mean that we've got less money available elsewhere. But we've got to work through those and identify what are the things that we've actually got decisions that we can make about. The second thing, and Matthew alluded to it, is that there is different payment mechanisms for elective and non-elective work. So it will be a block contract primarily for non-elective work in terms of moving that forward, but there will be a back to payment by results on elective work to incentivise extra activity. The mechanisms for that extra activity and guidance round about that are very complicated, and we will be working that through to understand what the benefits, opportunities, risks and threats are of that methodology.
Thank you for that good news. Thank you. Whilst people are thinking, can I come back, Matthew, just to bring some of this to life, because this is, I mean, when I read this, it's quite overwhelming in terms of the commitments we're making and the improvements we want to deliver. This is no small feat in the challenge environment that we're in. But just to bring it to life, I mean, you mentioned urgent and emergency care. Maybe somebody around the table could give us a flavour of what it is we would actually do to, say, improve A&E waiting times to hit that target, or improve the Category 2 and ambulance response when they say the problem is they can't employ enough people to answer the phones to get the ambulances there, and then the bed blocking issue. What interventions can we realistically make? So just those two.
I'm sure I'm happy for board members to come in, but I think that's what I've tried to say, that it's around a specific target. It really is about the system operating model, how we work together as a system. So we won't deliver the A&E 4-hour target unless we resolve the whole discharge and flow issue, because that's what's creating the pressure in terms of our emergency departments. And we won't be able to release our ambulances to achieve the Category 2 targets unless we resolve the flow. So there are lots of, that goes back to Aidan's question earlier, there's lots we can and are doing around trying to relieve the pressure. So we can think around the interventions we're trying to do around supporting clinical assessments through telephone triage. We can think around the work we're trying to do about avoiding our ambulances arriving at ED departments and making sure they go direct to same-day emergency care departments where appropriate. We can talk about the work we're doing in terms of integrating our discharge teams so that there are less points of contact and a more coordinated response. Stephen referred earlier to some of the work we're doing on managing the care home market to try and improve the utilisation of care home markets. We could reference the virtual ward work we're doing so that we have more capacity that is embedded to improve flow. So that's why I think it's really important that while the target looks quite specific, the interventions to improve the present performance are system-wide and complex. And that's not a criticism, it's a reasonable expectation that the work we do will result in the endpoint, but it does underplay the complexities of system working and the interventions we need to do, which goes back to the discharge money and that real focus on how we work together as a system to free up a bit more capacity in the system. Does that give a bit of
very helpful, a very valiant attempt to bring some of it to life. Really good. Yeah, Rachel.
I was just going to add, I think there's also something about us being brave in continuing to focus on some of the ill health prevention programs as well. So whilst we're front loading and investing in the here and the now, that we don't lose sight of how we prevent people becoming poorly and take more responsibility for their own personalised care, using the core 20+5 framework and the work that Rachel and her team are doing around prevention and driving up some of those inequalities that we're seeing so that we can avoid them tipping into our urgent emergency care pathway needed.
Really good point. Yeah. Just on that front, I was looking for some mention of smoking cessation, but it isn't specifically mentioned in this ops plan. I assume it's buried somewhere. Yeah, I thought so. Thank you. Aidan.
Yeah, I think that last point's a really important one, including the smoking cessation. And I mean, when I read this, I think I had the same sort of reaction as you, which is, well, what else do we fit in? And actually, if that's our objective, but I think it's really important that we do kind of cleave out that bit of, forward-looking strategic input so that we can, alter the pattern of some of this. Just in terms of a more specific question, Matthew, under the ICB governance bit, is there any likelihood that the Hewitt review outcomes will affect that, do you think? Is that in any significant way, and is that kind of in our thinking?
So I'm going to sorry, look at Steve and just, so I don't think the Hewitt review will fundamentally affect our operational planning process through this year. What it may have an impact on is how the ICB interacts and structures its support for transformation, oversight, delivery going forward. But I think in terms of the logistics of producing an operation plan, I don't think it has a direct read across. But I'm looking at Steve just to get confirmation of that from my chief executive.
Yeah, so I think exactly that. I think the planning guidance and the ICB's role in actually convening and supporting, as you've set out, will stay. I think the Hewitt review will potentially affect the size and scale of ICBs and potentially the pace of certain delegations into ICBs. So it may add a level of complexity in the face of us already delivering on what is a fairly robust agenda that's currently in front of us. And we'll have to take account of that in terms of what effect the Hewitt review has on our bandwidth capacity to respond. But I don't think it will fundamentally change what we have to deliver and our role in this planning guidance.
Certainly not for that year. It may have longer term implications.
It may have, that'll unfold some of the sort of different delegations that are being talked about, 23, 24 being a transition year on specialist commissioning delegations coming in 24, 25 into ICBs. And so I think there'll be some parallel running of that work together with what falls out of the Hewitt review. But certainly say for this next year, I think the planning guidance is the planning guidance and our role in it is pretty fixed.
Because the Hewitt review doesn't formally report until the end of March anyway, so it's too late in the timelines. Ross?
Yeah, thank you, Chair. Given the opportunities for digital and data transformation that the plans start to highlight, one of the areas I think the board should just be cited on is the challenge of the funding timescales that often come with this. So if I look at this year's financial transformation for electronic patient record systems, this morning I've still got the emails coming through about getting this year's funding out to the people who need to spend it to deliver in year. So one of the risks that we need to think about how we manage is what can we do around some of those choices to allow the teams locally to get on and deliver the right changes that unlock this capacity, because the current national funding model makes it very difficult for the system to make the real progress it's seeking to make.
And Ross and I have had a conversation about this, that I think the work that Ross is doing across the system with kind of colleagues is something we should definitely bring into probably both some sort of development conversation within the ICB board, so it's kind of we're collectively aware, but I think there's a really important probably conversation that we bring into this public board in March about the progression of some of the digital alignment into next year and beyond, because a bit like we've talked about workforce as being a challenging enabler, digital is both challenging but a positive enabler in terms of some of the things that we will want to do collectively across the system with our partners over the next period, and is not the panacea to some of the workforce challenges, but certainly is a component of how we may well need to be responding to some of those challenges over the coming years. So I think it's something the board should be cited and engaged on.
Yeah, sounds very sensible. Thank you. Right, let's move straight on then. Thank you then for that, Matthew, and everybody's contributions. The Board Assurance Committee report. So we've got 5 committees, and we're asking for reports now at every public board meeting, or meeting in public rather, from the chairs of those committees. Some of them are here and some will be represented in the report. So can we start, given that you're here, Tim, would you like to do system productivity?
Yeah, sure. It's relatively short and sweet, hopefully. So we've got it under the heading of things we should alert the board about, things we should advise the board about, and things we should assure the board about. So under the alert, it is our main area that we discussed, as you can imagine, with the month-based financial position, which Jim has gone through today in some depth, and a paper has been issued, and the paper you saw today is largely the same as the paper we saw on the 6th of January, which is when the meeting took place. So it was basically talking about the deficit reducing from 93 down to the 48 million you heard of today, and the stretch target of 44 million. The ICB itself within that is now targeting to projecting to break even, which is good news. So that was the main thing we absolutely feel the board should be aware of. In terms of advising the board, we talked again also about the capital plan earlier in this meeting, and we're looking to get, as Jim said, more detail on specifically what are the major projects within that capital plan, because of the fact that we're currently underspend, but yeah, we're projecting
Just press your button.
by year end.
Can you press your button, Tim?
Oh, sorry, apologies. You don't want me to go over that
No.
again? No, didn't think so. You've already heard it all anyway. We talked about continuing healthcare, and the next meeting, which is on the 7th of February, we will be having a deep dive into CHC, with a mind to what Stephen said, obviously, about not just manoeuvring the problem around, hopefully trying to understand where we are. And the other point was there's some really good collaboration going on between the ICB finance team led by Jim and the individual finance teams of the providers, and specifically I know that Neil with his BHT hat on has got a new CFO, and we're trying to work more closely with that team to get under the skin of those numbers. And then the positive news really was around the assurance we gained. So we had some good assurance from the digital team led by Ross on the day-to-day performance of digital, because we provide digital services to a large part of primary care, about all of primary care, I believe. And there's the metrics there are good and positive, which was good. Similarly, looking more further ahead, just based on what we just spoke about a moment ago, I think you're all aware that the ICS has 6 agreed digital priorities for the future, or currently and the future, and we got a good paper reassuring us on the progress on those. Did flag the point about funding timing, which Ross has just mentioned, but it was a positive position on those projects. We also got a good update from Jim on the contracts, the acute contracts that the different providers have, both within the system and without the system. And while there's still some uncertainty, Jim's team are on top of that and working well to get clarity with the providers and external providers, so good reassurance there. And last but by no means least, we've talked already, Rachel mentioned it earlier as well, we got a very positive report back from the Medicines Optimisation and Prescribing Savings Plan, which was saying, while it's challenging, the team are on target for what they've supposed to be achieving this year, so that was very positive. So overall, it was a good session.
Excellent. Thank you very much. Aidan, please continue.
Yeah, primary outcome from the meeting that we held, gosh, I'm thinking was it early December, I think, was the finalisation of the terms of reference, which I'm pleased to say have now been agreed by the committee. It's an interesting one because we're trying to define a space somewhere between this board, the ICB, and the ICP, without necessarily duplicating any of the work that exists in those two places, and creating hopefully some value. And I think the time and effort that we've put into defining those terms of reference has been, I think, helpful. They're attached in the paper if you want to have a look at them, as is a short kind of statement based on a kind of statement of intent around that, precisely for that reason of trying to clarify exactly what we exist for and what our objectives are. What we're looking forward to doing as we meet again.
Still got some gaps around our compliance against the national framework, and we will be taking a report throughout this year demonstrating the progress that we're making against our fundamental compliance requirements. And we spent time talking about the work that providers are doing and seeking the assurance from them around the progress against the Ockenden, the Kirkup reviews, and more recently into some of the mental health requirements that we've been asked to adhere to, so we can assure the board that that level of detail has been overseen. And I think lastly, I'm just going to bring Rachel in just to pick up on the work that we've done on understanding some of the clinical programmes that are being taken forward.
Yeah, happy to. So in each of our Population Health Patient Experience Committee, we focus on a deep dive in one of our clinical programmes, and it was stroke in the last committee, and we were very lucky to be joined by Dr Karuba Nagaratnam, who's a stroke physician at the Royal Berks, but also clinical lead for the Bob Stroke Network. And obviously it's incredibly important we prevent strokes for our population through modifying risk factors such as hypertension and cholesterol, making sure that our population have really good access to imaging, so that's CT, MRI, the type of drugs that they need to lessen complications, and make sure that we improve the availability and quality of rehab services. We have around 2,000 strokes a year, and our mortality and outcomes are on a par with the national. I think it's really important to bring in that the incidence of stroke in the most deprived quintile is double the incidence in the least deprived. So again, just weaving that golden thread through in terms of how we focus our interventions. And we work incredibly closely with multiple stakeholders in the network, including the Stroke Association. And I guess one of the main things is a national target of 10% of stroke patients to be referred for thrombectomy. And Bob has improved from 2.2 to 6.6% as a system, and that will hopefully improve further as OUH is able to expand its thrombectomy service from the hours it currently provides. So really valuable to have that kind of deep dive into a network and clinical representation from it.
Great. And the committee has quite a wide-ranging membership, doesn't it? I think from the one that I popped into, and are Health Watch represented?
Yeah, they are.
So patient experience is included within that
Absolutely.
as well. Yeah,
Yes.
great, excellent, thank you. Now, normally Sim Skavazza would be here to talk about the People Committee, but Catherine, you're going to cover for her?
Yes, she's sent some points. Before I do people, can I just go back to being specific for the place and system development, that we're asking for board approval of those terms of reference on the statement of intent, because it's for the board to approve on recommendation from the committee. So people, Sim says they've had 2 meetings. They've now got some terms of reference to be sending to us. They'll come to the March meeting, as they only held their second meeting last week. Shows there's very good participation at system level with local authorities, voluntary sector, trusts and primary care. And as part of it, they've got a no duplication agreement, that this must be about added value at the system level. So for an example, seed funding for innovative system ideas. And their first priority is to work on the people plan for the ICB in the first instance before formulating a wider plan for the system.
Okay, thank you. Short and succinct. Just come back to your point about what we need to approve. Are those papers in the...
Yes. Right at the end.
Yes.
Right at the end. Okay. Right. We'll come back to that in a minute after the last report. And Saki, back just in time to give your report on audit and risk.
Right. So thank you. So as you can see, we actually had our first meeting of this year on the 3rd of January. So it was in the afternoon on the first day back. Good progress on various areas. So board assurance framework coming along, single tender waivers. We agreed the way that we're going to move forward. So we're not approving them, but we're following a process. Information and governance was brought there on counter fraud, continuing to follow our plans. On the audit plans, risk and governance was reviewed, and the HFMA framework, and then the external audit plan, which is obviously important for this year as we move into the last 3 months. That's on target. There will be 2 sets of accounts, as has been previously mentioned. There'll be the accounts for the 3 months of the CCG, and then there'll be the accounts then for the 9 months of the ICB. And that's my update. So,
Thank you very much. Excellent, really helpful summary. That includes everybody, I think.
And there's some proposed changes to the scheme of reservation and delegation, which again are in the annex. And I'm sorry, they provide loads of papers, loads of pages of the papers, but we've highlighted all the changes which the audit committee are recommending to the board.
Do we have everyone's agreement to those changes? Yeah, great. Thank you very much. And let's move on to our last formal paper then. This is the paper from Matthew.
Thank you, Chair. So this is part of our formal responsibilities under the Civil Contingencies Act around EPRR responses. So just a couple of bits of context. So as we were established in ICB, we did become a Category 1 responder, and that they're organisations that are core to the response across the public sector and the civil protection duties. Just to note, CCGs were Category 2 responders, so that is a step change from the responsibilities we were operating under in the system when CCGs were established. So that does give us an additional set of responsibilities. In terms of what the paper outlines, it does 2 things really. It outlines the assurance process that we run and coordinate in terms of overseeing our partner processes for compliance against the core standards on EPRR, but it more formally outlines our organisational position. So you'll note that part of the paper is to note, which is that our overview and assurance of our provider organisations across the system, and it's to ratify and approve the ICB response. At summary level, I think all of our providers are in a strong position. As long as we're substantially compliant or fully compliant, then that's comfortable. There are areas to work on, and it's unusual not to have areas to work on, but credit to the Exeter Health team for putting in a fully compliant position. But the rest don't identify any major issues, and you see that the team have done a neat little table there identifying just some of the examples of areas that trusts and partners are working on to work towards full compliance. From an ICB perspective, it's relatively simple, our non-compliance. We're not a well-resourced team, so I think we've managed to do what we needed to do this year, but actually in reality our dedicated EPRR response resources is 1 individual. Well, that was the case up until the 9th of January. I'm delighted to say that resource is now 2 individuals, with a head of EPRR, Alexander Thompson, joining on the 9th of January. So that's a real injection of dedicated resource. But comparatively, we're still a very short, light team, and in the consultation document there is a request to and a plan to expand that team further. So we have done what we needed to do, but I think it's important to highlight that resource constraint which will allow us to progress further this year. And before I open up for questions, probably just to say that there are lots and lots of live examples this year of EPRR management and incident response, and those are listed on the second page, the page of the report. So ranging from dealing with Storm Eunice to Operation London Bridge to a standard winter response, you can see the amount of incidents that both the ICB and the broader system partners have tried to respond to. And you can see from those that if you get the advanced outage, for example, was a particular issue for Oxford Health in particular in terms of the level of the incidents, but they will vary across the patch. It gives a flavour of how stretched the organisation and the system's been in terms of incident response. So hopefully that gives you a flavour of the wider reports here, Jared, and board members. Happy to take questions and comments.
Thank you very much. So we're asked to note the main report. Are there any questions, comments anybody would like to add? Aidan and Steve.
Yeah, just in terms of assurance, Matthew, what's the kind of cadence of us seeing the regular data to enable us to be assured that we're compliant with the with EPRR as a body, as a corporate body?
Hold that. Let's hear from Steve as well. He's conscious of time.
So it's just a quick question, my ignorance, Matthew. What, from an ICB point of view, as a Cat 1 responder, what's our? Do we have any requirements to either coordinate or run any LiveX? Oh, we're Cat 1.
Yes.
Yeah, because we've moved from Cat 2 to Cat 1. Yeah. So I just wasn't sure. There clearly is on providers to run a program of LiveX every 3 years or something like that. But do we have any?
LiveX, you mean?
So live exercises. So
Okay. I thought I was just double checking. Yes. So there is an expectation for us to do that, as with providers. There is a reality that if you've been running live events, actual real live events, then that does have that does mean that you don't have to necessarily run exercises. So we're working through that, but we will have to. That's part of the additional resource. We'll have to run live events on an annual basis, but you can compensate for that if you've been running
real live events,
which is
you have plenty of real live events.
So that's hopefully. So in terms of assurance, so this is a report that will come every year to the ICB board. I've discussed with Catherine about where this sits in our committee architecture, so we will work with the audit committee in terms of how that runs through that for assurance going forward into next year.
Thank you. Okay, with that discussion then, do I have your support on the statement of compliance? Yep. Thank you very much. Great. Then in the agenda papers you also have the forward plan, which as you'll see gives you an indication of what's coming towards various meetings up until the 21st of March. And I believe that the next version of this should be created for the following 12 months, which we should have tabled next time we meet. Yeah, hopefully that's helpful. Is there any other business? I'm just looking around. I haven't been informed of any. Thank you very much. So it just falls on me then to just thank everybody here, all board members and all presenters, all of the work that goes on behind the scenes. Of course, you know, these papers take a lot of time and they are only a snapshot of what is going on. There's much, much more than this. And to thank all the members of the public that have appeared and have very quietly sat in the audience. And hopefully you found this a good use of your time. Your views do matter, so do please stay in touch with us and send in any questions that you have. And as I said right at the start, we will publish responses and any other things that you might be interested in asking us about. At the end of the day, we're here because we're here to represent the public and try and respond as effectively as we can using public resource to the needs of the complex needs of the public in terms of integrated health and care. And if we're not getting that right, you need to tell us. And by some miracle, it is exactly 1 o'clock. Thank you, everybody, for your time. Right.
Well done, Trevor.